Good morning, everyone, and thank you for joining us virtually for Withum's second annual Healthcare Symposium. My name is Rachel Gisser, Senior Marketing Coordinator of Withum's Healthcare Services Group. We have an exciting program planned for you today. Industry experts will share their insight on the latest developments in the current healthcare landscape to put your organization in a position of strength in today's health economy. Topics include the actions taken by the leader of the healthcare system at the epicenter of the start of the pandemic, financial aspects of COVID-19, board and governance considerations for your organization and the implications for the future of the industry from a behavioral health perspective and as it relates to the workforce. All sessions will begin on the hour with intros beginning at 5 of. We'll be offering 4 CPE, CLE, and ACHE credits for this program. I will go into those details a little later on how to qualify. On the right of your screen, you will see a toolbar where the handouts for today's session are located, as well as a chat box for questions. During the program, feel free to write in questions and we will do our best to address them. With that, it is my pleasure to introduce Withum's CEO and Managing Partner, Bill Hageman.
Thank you, Rachel, and thank you all for attending and welcome to my home where I've been since March 16th. I've been in the office a total of 4 days as we all wrestle with this pandemic. And I want to really thank everybody for taking the time to be on this call. Over 500 people have signed up, and everybody is a healthcare professional one way or another, which means that this pandemic has really impacted everybody here in a very personal way. You're dealing with it every day, and in us as accountants and auditors and tax professionals, advisors, really can do nothing but thank you all for the efforts that you put through by being on the front line, whether you're in the finance department supporting the people that are working in the ERs and working in critical care areas, or your actual in the hospital, the operation of the hospital. I mean, it's God's work you're doing right now, and our society will owe you a debt of gratitude for a very long time. We're very excited to present this healthcare symposium. Very excited to do this virtually. We have actually found at our firm that going virtual hasn't been as painful as some of us would have surmised a year ago. We've been able to effectively reach out to our clients, effectively get work done, effectively provide the world-class client service that we've become known for. Our team in the healthcare group has been working very hard with our clients on CARES Act criteria and other areas where we think the hospitals, physician services, and other parts of the healthcare ecosystem have been wanting. We've seen with the pandemic, we've seen an uptick in cyber issues. Our cybersecurity team is incredibly busy working through that, working with our clients and protecting data and coming up with strategies so that they can move forward and be able to so that they can move forward and be able to protect the all important data that all of our healthcare clients have on their servers or in the cloud. As we think about the economy and where it's going to go, obviously what we're all hopeful for is probably the same thing everybody else here is hopeful for, and that is some action from Congress. And I really don't want to be political. However, I think it's an apolitical statement to say that we need support, we need stimulus, and we look forward to being able to get that, and then helping our clients understand what that means. But generally speaking, when we look at the economy, there is some overall concerns that we're coming into some bit of a turn down in the economy. This recession has impacted very specific areas, obviously restaurants, hotels, the travel industry. We have not seen that in our other industry sectors. And as people have been at home and still had the ability to spend money, things like manufacturing and other industry sectors are actually doing quite well. But over the long term, we do expect that there's going to be some trickle effect on all of us that are sitting on a phone today. So we are advising our clients to be conservative, to maintain liquidity, And let's all hope that that we can get a federal package that'll basically help get us through the last part of this as we look forward to the vaccine and maybe getting back to normal in the second half of 21 and certainly into 22. I know you have a session later on managing through the pandemic, and I know that, so I don't want to step on any of those. But when I think about our firm, we've been able to, as I said, manage through the pandemic. But what I'd like everyone to think about is how you manage post-pandemic. I do think that we've learned a lot of really critical lessons, and I think the ability to use technology like this is really going to make us rethink how much we spend on travel, how much effort we put in travel, because what we always take for granted is there is a personal toll on our physical abilities when we're traveling, right? And what I've been telling our partners and staff is I could definitely see a world where people work from home 2 to 3 days a week, especially if you have the white collar jobs that all our folks have. You work from home 2 or 3 days a week, saving your commute, saving the dollars, and we should be able to effectively continue to run our businesses, effectively to continue to be able to service our clients. So as we look forward to the future, I think thinking about what we're going to look like post-pandemic, which hopefully is only 12 months away, or maybe less, is something that we need to take into consideration. So with that, I will just say once more that thank you all for joining us. Thank you all for being clients of our firm. We treasure every single one of you, and thank you for the opportunity for us to serve you. With that, I'm going to kick it back to Rachel, and we'll get this thing started.
Thank you, Bill. So here is a quick look at our agenda for today. And here is the CPE, NJCLE, and ACHE credit information. To qualify for credit, you must answer each polling question throughout the program and complete the survey at the end. The questions will launch every 15 minutes, so please be prepared on every 15, 30, and 45-minute mark of the hour. You may note that the polling questions are unrelated to the keynote or panel sessions, but they are relevant topics our professionals see in the healthcare industry today. Withum will handle CPE, and the NJHA will be distributing CLE and ACHE credits, and certificates will be emailed by December 11th if you meet the criteria of answering the polling questions and completing the survey. More information can be found on the following slides. I will now turn it over to Scott Mariani.
Thank you, Rachel. Good morning, everybody. I'm Scott Mariani, partner and practice leader of Withum's Healthcare Services Group. I'd like to welcome you to Withum's Healthcare Symposium. We are thrilled you are joining us today. We have a great lineup of speakers, topics, and a very interesting program. At this time, we'd like to acknowledge and thank our collaborators for this year's event. The New Jersey Hospital Association has partnered with us again this year, and would like to thank the organization. Specifically, Kathy Bennett and Sean Hopkins for their participation today, and Roger Sorrow and the entire NJHA team in helping us plan the agenda, topics, and presenters, and coordinating CLE and ACHE credits. NJHA is doing some really terrific things for the healthcare industry and residents in the state of New Jersey, and we encourage everyone to check their website to review some of the great work they are doing, including their COVID information and involvement throughout the pandemic. And we'll hear from Sean Hopkins and Kathy Bennett today. The annual community benefit report and the report on social gaps and their impact on health, New Jersey's most vulnerable zip codes study that they published. In addition, we would like to thank the New Jersey HFMA for partnering with us again this year and their valuable input throughout the symposium planning. Also, specifically, the New Jersey FACT Committee, Finance, Accounting, Capital, and Taxation, for their involvement with suggested topics and presenters. And we want to recognize and thank Stacy Medeiros, current president of New Jersey HFMA, The FACT co-chairs, Alex Filipiak and Spiro Leonis, and Dave Murray, board liaison to the New Jersey HFMA FACT Committee. Lastly, we want to thank all of these other regional associations who contribute to making the symposium a success this year, including the Central PA HFMA chapter and the Northeast HFMA chapter for assisting us with planning the symposium and suggesting presenters as well. Now, at this time, it is my pleasure to introduce today's keynote presenter and speaker, Michael Maron, President and CEO of Holy Name Medical Center, who will begin our program this morning. A little background. Michael joined Holy Name Medical Center in 1987 as Vice President and Chief Financial Officer and was promoted to Senior Vice President in 1991. In January of 1997, he was appointed President and Chief Executive Officer and continues in this role today. Mr. Maron received a Bachelor of Science degree in Business Administration with a concentration in accounting and a Bachelor of Science degree in Health Services Administration from Providence College in Rhode Island. He received his Master of Business Administration degree from Columbia University Business School in New York City. Mr. Maron is a member of the American College of Healthcare Executives, the Board of Directors of the New Jersey Hospital Association, the St. George University Advisory Board, and a board of the Commerce and Industry Association of New Jersey and its Healthcare Steering Committee. Mike is a well-respected New Jersey healthcare leader who has worked tirelessly for and has contributed to the New Jersey healthcare industry for many years, always stepping up into leadership roles and making sure what is right and best for the healthcare industry, the communities, the patients, and the hospitals and healthcare systems. Based in Teaneck, Bergen County, New Jersey, Holy Name Health encompasses numerous facilities in the northern New Jersey area, including Holy Name Medical Center, which was New Jersey's epicenter of the COVID-19 pandemic, a comprehensive licensed 361-bed acute care facility which provides technologically advanced, compassionate, and personalized care across a continuum that encompasses education, prevention, diagnosis, treatment, rehabilitation, and wellness maintenance. The medical center has nearly 4,000 employees and admits approximately 30,000 patients each year. Mr. Maron guided the organization seamlessly through the confusion and disruption of COVID. He also personally contracted the virus himself. Please join me in welcoming Michael at this time. Michael. Thank you.
Good morning, Scott. Thank you so much for that beautiful introduction. I'm not quite sure who you were talking about, but it made it sound very, very good. So I am humbled and honored to be here this morning. I want to thank Bill and yourself and Rachel for inviting me to tell our story. It's a little bit of a, hopefully a unique and different story. Let me see if I can get my my screen up here. Okay, that did not happen. I'm not sure, Rachel, Scott, can you see my screen yet?
Can't see it yet. I can make it on mine if you'd like.
Let me just try one more time. It was how's that?
Still not yet.
I am not coming up on the presenter list, Rachel.
Did something pop up when, because right now it says waiting to view screen.
Yeah, it says make presenter and it has Bill and Dave, Mike Saluco, Scott, Sean Hopkins, you as the organizer. My name's not appearing as a option
Let me
to
get back
present.
to myself and then let me select you again. And then if not, I can just put it on mine. All right, so, okay, so making you the presenter, something should pop up on your main screen and then you
Yep.
can click share.
Click show this window. Not yet.
Not yet.
It popped up and it click said show this window.
Maybe do you have multiple screens? Are you able to move maybe the presentation on a different screen?
No, my presentation's on the same window screen. I had moved it over.
Huh. I can just share it on mine.
Okay.
Okay. All right. Let me get back.
There we go. Okay, so sorry for the technical glitch, everybody. But again, good morning and thank you for having me here. Let me just start a little bit about what I'll try to talk about today and answer questions as best we can when they arise. It's a little bit of the past, a little bit of the present, and a little bit of the future from my perspective. I will throw out some provocative stuff, not because it's what we necessarily believe, but I think this is a time that we all need to challenge ourselves to break some traditional molds and think a little bit differently about where we're going and what we can learn from this. So the opening screenshot you'll see is the front of Holy Name, and our elevator tower there normally houses our Egyptian Ankh. For those who do not know, the Ankh is a symbol of life. And what we did after March and April was dress that window with lights, the white lights basically representing the lives we saved, the red lights representing the lives we lost. And that is basically statistically proportional to the experience that we had here at Holy Name, and had a nice lull in the summer. And unfortunately, as everybody knows, we're seeing it back now in the fall, and just in recent weeks, really picking up again. We can go to the next slide, Rich. So a little bit about Holy Name. People know we're 361 bed general acute hospital. We're with physician practices that we now are part of Holy Name Medical Partners and our clinically integrated network of over 900. We are one of the few independents left and one of the few Catholic hospitals left in the region. What we did is expand outside of the U.S. We have a 200-bed hospital in northern Haiti, Hôpital Sacré-Cœur, in a small town of Milo, just south of Cap-Haïtien. And we've operated that facility for the last 10 years. And then we have a very unique 20-bed dedicated inpatient hospice facility, one of a kind. It's all we do is end-of-life care, and that's the Villa Marie Claire. So some background on Holy Name. Next, Rach. So our story actually began at September 11th, 2001, and would not have thought that would have carried over into 2020, but it did. Holy Name is built on a hill in Teaneck, just across from Manhattan, and from our upper floors, we had a bird's eye view of what happened at 9/11 and saw the towers get hit, saw them fall. And after that, we had decided that it was time to rebuild our emergency room and do so. And we ended up doing it in conjunction with Shaare Zedek Medical Center out of Jerusalem, who was also rebuilding their ER. And no surprise to everybody, Israel is much more advanced than we are in terms of catastrophic event management, how to design and how to respond. And so Shaare Zedek was invaluable to us in reconfiguring our emergency room design and build. And so part of that is outdoor space, and the pictures that you see on the right with the ambulance, the entrance. It's a freestanding, isolated building, has its own energy supply, its own air supply in the event of quarantine. And then the upper picture there is our auditorium. In Israel, it is now standard building design when they rebuild hospitals and do additions to go underground, so that in the event of bombing attacks, they can move their patients quickly below ground into safe quarters. And so Holy Name is built into a hill, and this conference center was our space that was designed for that purpose. We've never used it for that purpose. It's always been an auditorium, and until now, as you will see when we go through. Next slide. So inside that ER space, there's 44 rooms, all single, all isolated, but they have the head walls capacity to double up in the event of a catastrophe, which they did. What's unique about these rooms is they were designed specifically to extend the effectiveness of caregivers. So every room has computers and audio and video components to it, so that when a patient is in there, a provider, a physician, a nurse practitioner, a PA, a nurse themselves can basically care for you, write orders, see all your vitals, see what's going on. They can do everything but touch you, and they can do it remotely. They could do it from remote within the hospital. They could do it remote outside the hospital. And so it takes one person who is going to be put in harm's way, if you will, as a staff person, and extend their effectiveness out considerably in the event of a catastrophe and a crisis, which we've been experiencing. And so this proved invaluable to us in our ability to respond and quickly care for the people who surged into our ER during the crisis in March and April. Next slide. So this absolutely hit home to us. We lost some of our beloved employees. This is one of our transporters, a 76-year-old man, Jesus, who had worked here for 26 years. He was an absolute gentleman and a saint. Community acquired COVID and ended up passing away here. He was one of our first casualties. The first admission to Holy Name was in March 4th. And so we started ramping up and building. But this is his manager wheeling him out from one of our temporary critical care areas to the morgue, surrounded by staff. And so it became very personal at this stage for us at Holy Name. Next slide. So what we did is we started to worry about staffing. We worried about PPE. As everybody knows, back in March and April, that was a huge issue, is where it was coming from. And one of our ICU nurses came up with the great idea and said, you know, we have to don and doff repeatedly just to go in and turn off IV pump alarms or replace IV bags or check monitors. And so we moved everything outside the rooms. So every room had holes drilled in the walls, and all the IV pumps, all the monitors where they could be, all the ventilators eventually all came outside the rooms, saving PPE. We actually saw a 70% drop in our utilization of PPE by doing this. And so that, again, took stress off the staff, saved on preserving precious PPE at the time. And so we took this concept now to a whole grander scale. Next slide, Rach. So as I said, here you can see the staff working on the pumps outside. Proved very, very effective. The patients actually liked it because the alarms weren't going off. So those who were not intubated and were alert and able to respond, knew that it was a little quieter inside the room because all the noise and the activity was on the outside. And the nursing staff were able to keep themselves more frequently out of harm's way, if you will, preserve that PPE and make themselves much more efficient in terms of caring for the patients that were in such demand. Next slide. So we went through and not pretty, but we revamped almost the entire organization. We went from about 20 negative pressure rooms up to 276. What struck me most in the beginning here, which was surprising to me, it's where facilities and engineers and physicians and caregivers don't always necessarily understand each other. A lot of our top doctors did not understand the whole concept of negative pressure. And so they weren't sure what it was. Does it protect the person in the room? Does it protect the person outside the room? And we had a lot of debate around the importance of negative pressure in an airborne virus like COVID-19. And so what we did is finally convince them that negative pressure does not protect the person inside the room. It protects everybody outside the negative pressure zone. And I'll show you why we now refer to it as a zone, because it's more than just a room or an area. And what we were able to do is increase air exchanges from a typical 12 per hour up to 25 per hour in large spaces, and as you'll see in other areas, significantly higher than that, to expel any airborne virus that would be in the area. This proved highly beneficial to us as we went back and reviewed all of the Holy Name employees, anybody who tested positive for COVID along the way. All were community acquired. We have no single case of a patient to staff transfer of COVID-19 at Holy Name. And part of that is because of the incredible efforts of our facility crews to convert such large portions of the facility to negative pressure. Next slide, Major. So again, not pretty, but in the middle of the crisis, neither the employees or the patients cared. A lot of plastic walls, plastic doorways to create those negative pressure zones. You can always tell when the negative pressure is working because the plastic will be sucked in, right? So you don't need the fancy digital monitors. You go back to some simple old school methods, and it's literally leaving a slight unzipped portion of the door, of the plastic doors. And when the plastic is being sucked into the room, you know that there's negative pressure there, that the virus itself is inside the room being expelled out, and the likelihood of it coming outside is pretty small. And so most of the facility here had plastic like this draped one way or the other through all that period, and especially in March and April when we were ramping up so quickly to respond to what was happening. Next slide. What we then did is created what we call isopods. And so we took the concept of negative pressure and said when we're transporting and moving patients, that was viewed as a high risk moment in their care here. And how do we protect all those transporting? And so we developed these isolation pods that would go over a stretcher for transport. And then we took it to the next level and said, if we have to start to cohort patients in rooms because of demand and space constraints, building a plexiglass shell. This is all Home Depot supplied material, not necessarily health grade, but in the middle of a crisis, it worked. And we designed this isopod that would basically shield the patient on their bed. Each one of these would have a negative pressure air vacuum line attached to it. And inside those, the exchange rates went up to 400 plus or to 1,000 plus, or in the case of patients either having C-sections or needing to go to the OR, that's lower right, a smaller unit so that the surgeons could have access, but that is 5,000 air exchanges per hour. So any sick patient whose head is within those shells, the virus itself is never going to escape outside the shell, providing another layer of protection to staff. Next slide. We tested that to make sure that it worked in our simulation center. So we have, Holy Name is fortunate to have a very robust, very contemporary simulation learning center. We use it for a lot more than just basic simulation training. And in this case, as the design went through its iterations, we use simulation training to test, prove, verify that that would actually work and that it would be functional, that the nurses and staff would have access to the patients, that the vacuum system would work the way it was supposed to, that patients would be comfortable and not feel claustrophobic. So there was very rapid, very quick, real-time turnaround in terms of testing this concept and then rolling it out to the rest of the organization. There were over 250 of these isopods built by our staff, and it wasn't just our facility and maintenance staff, it was any personnel who had carpentry skills, and you'd be surprised how many nurses and radiology techs and even physicians are carpenter hobbyists, and so we deployed them when they were free to our facilities, and they built 250 of these in 2 days. Next slide. As demand grew, we then said we have to expand out and we have to try to make our nurses even safer and a little more efficient. We were worried about staff burnout. We were worried about the efficiency of staffing and, again, preserving PPE. So our first attempt at this was very crude, but very, very functional. And we took shell space that had not yet was intended for new operating rooms. We obviously postponed that construction and constructed in here large ward areas that would hold intubated patients. This was put up in 7 days with full medical gases, with full plumbing, so that you could do dialysis on those who went into renal failure, with full functionality, so that all IV pumps, all cardiac monitoring and all ventilators were outside the room. Windows, large windows spanning around the outside so that the staff could see in. And this way, only 1 or 2 staff people would have to enter the contaminated space at any point in time. The other staff would be outside. They could communicate with each other. And again, extending the overall efficiency of care and of our staff and how they cared for people. Hard to see on the picture on the right, but coming out of the temporary ceiling there are a bunch of vents. So again, with the ability over every bed, if need be, these patients are all on ventilators, so it's not required. But as they started to wake or required, we could put one of those isopods over an individual bed and keep that individual as they were expelling any potential virus from contaminating the rest of the space. Next slide, Rach. So working off of that, we then decided to refine the concept, and we went down to that auditorium that was intended and designed 20 years earlier to be, 19 years earlier, to be extra space, and refined the concept and built an additional 3 units of 36 beds. And again, this one was done in just over 7 days, to convert from what it literally looked like on day 1 on your left, which was auditorium space with carpeting and conference tables, to the 2 pictures on the right, how it looked several days later as staff worked around the clock, ripping up the carpeting, putting up the walls, and refining that concept. So in this area, we added mirrors so that when staff are on the outside, they could look at the mirror and see the patient's face, because the head wall is up against the glass. The glass walls are larger. The walls themselves are all constructed of PVC and finished much nicer on the outside so that the monitors are mounted easier. The pass-throughs for the lines and the electricity much better. The source of medical gas and oxygen significantly greater on all sides. And so a much more improved space. Curtains, privacy curtains now, so that as patients were awake or alert of their surroundings, that there would be some privacy here. But again, this just extended the overall efficiency of our staff exponentially compared to what it was if they were all in individual rooms. And it, because of the negative pressure concept, allowed our staff to preserve PPE and keep themselves out of harm's way. When you're outside in this monitor area, the far picture on the right, that is a completely safe zone. So you have to continue to do hand washing, you have to continue to observe, and people would still wear their surgical masks in that area, but N95 is really not required because all the virus is contained on the inside of the pods and extracted through the negative pressure concept in that area. Next slide. And again, just some more graphics to show the efficiency of how this all filled up and how the staff were able to operate here and protect themselves and provide great care. Believe it or not, again, in the middle of the crisis, the patient satisfaction was significantly higher. We were concerned a little bit about patients balking over the lack of privacy related to an open ward kind of design concept. But fear is a very powerful force in many, many factors, and fear has been the number one dominant force through this entire crisis. And so when you're afraid of the impact of the virus on you, your settings become much less important. And the fact that you know that you're being cared for trumps all of that. And people were extremely grateful to be able to just get in and to have staff caring for them. And so patient satisfaction here was actually very, very high. Staff satisfaction very, very high because of the extended efforts it took for us to keep everybody safe. Next slide, Mitch. And again, just a couple more. So here, all these areas with plumbing, that bottom left picture for dialysis, because as we saw, as many of these patients did deteriorate and were intubated, that renal failure was one of the more common conditions that arose. And so we had to put people on acute dialysis. And so all of these stations were equipped now for dialysis as well as the monitoring. And you can see the difference between the original sort of crude wood framing design that was highly functional and a little tight compared to the improved design. All of these spaces were done within 14 days, which is nothing short of an engineering and facility build miracle, and all done for the most part by internal staff. At one point, I actually had two of my own sons commissioned here, working as laborers, helping to build this. So we took volunteers, we took people from the outside, but we were able to get it done on a very, very quick and expedited basis. Next slide. So where are we now? This map actually is from about a week ago. It shows the US, the proliferation of positive testing throughout. And one of the things that the next few slides that I'm going to talk about is back in March and April, you don't hear it so much anymore today. It was all about flatten the curve. And it was all about mitigating the risk of spread. But when you look at this chart, you realize just how interconnected, interdependent we are. And so we can do things here in New Jersey to a certain point, but we can't lose sight of the fact that we're part of a large country and part of a interconnected globe that I'm going to talk about that had significant impact across. And so that micro view, helpful and beneficial, but somewhat misleading, because we are at the mercy because of that interconnectedness as to everything else that's going around us. And so it shows the widespread testing, and especially when you look at the New York, New Jersey density of the proliferation of the virus in our area. But it just gives you a great visual graphic of just how widespread. There are no more safe zones. There are no more waves, if you will, going through. The entire country is now infected. The horses are out of the barn, and so we still try and talk about ways of getting them back in. I think those days are way behind us. Next slide.
Thanks, Mike. I'm just going to launch our first polling question right here real quick.
Sure.
Has your organization's finance accounts payable department begun to address the changes in the new 1099 NEC and 1099 MISC? About 25 more seconds, everyone. All right, I'm going to close it out. And here are the results. Looks like about 34% of you said yes. And while that was going on, a question had come in during the presentation for you, Mike. What COVID-driven changes within a healthcare system do you think will remain permanently?
So there are many. Many of those systems, and I'll talk about this later in the slide presentation. So many of the functions, many of the things that we learned in terms of our ability to be responsive are going to become permanent parts of our operations going forward. We cannot assume, and it would be irresponsible, I think, at this stage to assume that this is another 100-year event and we won't see anything like this for another 100 years, right? So we referenced the Spanish flu in 1918, which ironically was the impetus for the founding of Holy Name in 1925. We were born out of response to the Spanish flu in 1918. But this is very different. And so I think infectious disease and viruses of this nature are going to be part of the norm going forward. And so we got to be better prepared. And so a lot of the components, those units that we showed in Marion Hall in our auditorium, we're going to, when we get through this at some point, not quite sure when, but we've already started on the design and plan to convert those to modular, so we can actually store them in our warehouse. And if another crisis does hit, we can take them out and reconstruct and put Marion Hall much quicker with much less angst and anxiety into quick overflow space. And so things of that nature are facility designs and changes going forward are going to become permanent. And then I'm going to talk a little bit about technology, the application of technology, this kind of conferencing. This is the new norm. And as Bill had said earlier in his opening remarks, there is an incredible efficiency to this. I know most people don't like it. We're humans. We need and cherish the personal touch and the face-to-face. And this isn't necessarily a long-term substitute for that, but it is undeniable that this kind of technology will absolutely accelerate and be part of our main operating processes in every industry, healthcare, financial services, doesn't matter where, going forward, because its effectiveness and its efficiency. And there's a whole host of other technologies that I'll talk about in a little bit that will be long-term and I think permanent. So the flatten the curve, and again, you've probably seen this. This is through November 17th. These are global numbers. And so again, I'm a big proponent on the fact that with this virus and because of the nature of how it's spread globally, we really have to look at and should always go to that macro global view. When you look at individual states, it's beneficial and necessary, but it can also be misleading because of everything, and we are dependent on what's going on around us. And so you'll see different curves at that micro level where they spiked in March and April, and then they flattened out, and we came to the lower side of the curve, and then they start their fall uptick that we're seeing now. But when you condense the globe, you don't have that kind of a curve. You have a steady increasing curve. And this is really the one that as public health, as epidemiologists across the globe try to combat this virus, this is the one that's more important. And so when we think about this globally, we really haven't flattened the curve. It's continued to grow since its onset back in January through November. And so the number of daily cases now globally are higher than they were back in March and April. The good news, and again, one that's not talked about a lot, and these are hard discussions to have, that when you look at the actual recovery rate, the bottom graph and the green line on the top, we have become much more successful. We had our blip in our learning curve, if you will, in March and April, and unfortunately it was New Jersey and New York that felt the brunt of that learning curve, where deaths were much higher and the recovery rate was lower. But then it evened out and we figured out things a little bit better. Still not acceptable, right? The death rate is still very high, but the recovery rate is very, very high. And so we are making progress, and those are hard to see, but they're trending in the right direction with the new interventions and the new lines. But the important part here is this flatten the curve. And we talked about it. And in one of my other discussions, and what I'm going to take you through now, is what I've defined as the 5 curves really associated with COVID. We heard about this one a lot. The other 4 are kind of my own. They're not in the public domain anywhere, but I will share them with you now to give you a better sense of what else is going on and important with COVID. And one of those is the learning curve. So a traditional learning curve looks like this. The first quadrant, if you will, is our inexperience, and the middle quadrant is when we become engaged and start to learn and improve. And then the final quadrant is mastery and how we do it. And I put an arrow where, in my opinion, this is kind of where we are. We're still very low on the learning curve, even after all this time, given everything that's gone on and the volume of virus that's around the globe. We are still relatively low on that learning curve. And that's something that should be humbling and should be respected, because people are anxious, they're fearful, they're looking for absolutes. There are none. And we as an industry and as professionals are sometimes reluctant to admit that we don't know what we don't know. And because it's somehow interpreted as an admission of weakness. But if you look on the left, the things that we don't know, we really don't know the transmission mode. We really don't know the contagious period. We're not sure of the immunity timeline. We have no idea what the long-term effects are because we haven't been in it long-term. We don't know why some people crash and others recover. When you look at that previous graph, like, so all those people who do recover, what was different about them than the individuals who crashed and ultimately died? We don't know. Where are we with vaccine development? So that's new, right? And we're moving very, very quickly, which is good. Have we really altered and improved our response preparedness? Masks, right? Still to this day, there is a lot of controversy and a lot of misunderstanding around the importance of the utility of masks or not. And we see demonstrations all over the country as people in the globe, as people say, I'm not going to do this. The impact of contact tracing, which again, I have a unique response as someone who's actually taught in the public health sector, both at Columbia and Johns Hopkins. I have a more contemporary view. And then overall surveillance. So these are all areas that we're actually pretty low on the learning curve on. If we go to the next slide, just as to drive home that point on masks, this is a very effective graphic that we've used here. I know others have used it because people still in the large population out there do not understand why they're wearing a mask. And most people still believe that the mask is protecting themselves. And so if you look at it in these 4 levels of risk mitigation, and no absolutes, it's all about risk mitigation. In the first scenario where the COVID carrier doesn't wear a mask and you don't wear a mask, that is the highest level of risk that exists in an encounter. When the COVID carrier does not wear a mask and you wear a mask, it is the second highest risk capacity. When the COVID carrier wears the mask and you don't have the mask on, that is the second lowest risk scenario. And then the final safest risk scenario is when both people have a mask. And so people don't really understand this. And a lot of people will turn around and say, we've seen this publicly now where I had the virus, I don't need to wear a mask, I'm immune. That's great, except no one else knows that, and you're not wearing a star that says that you had the virus. And so it's important, especially important for leadership to set the tone wear a mask, because when everybody wears a mask, whether you have it or not, then you know the risk of spread is very, very low. And the other one that I would plead to people, and I'll do this a little stronger a little later, is you need to be honest with yourselves. And we see this now a lot. If you don't feel well, and the symptoms that we saw back in March and April are not the dominant symptoms anymore. It's not fever. It's not severe respiratory distress. It's all the others. It's fatigue. It's the loss of taste, the swelling in your mouth. It's chills that most people do not equate to a fever. It's digestive issues. Right? There's a whole host of other symptoms that are now more prominent than just fever. And so if you don't feel well, then be honest with yourself. And that could just be, I feel off. Make sure you wear a mask and try to self-isolate. And if more people were honest with themselves through this, I think the spread would deteriorate significantly. But people are pressed and people are fatigued and people have all sorts of other pressures. This is not a blame game. This is just a citing reality in terms of if we raise our self-awareness in terms of how we're feeling and then respond accordingly, we all have a responsibility to help lower this, and that's important for us to pursue. Next slide. So the economic curve for you guys, very important, and there's multiple ones here, as we know, right? So we're in a recession, COVID hits, we have 2 quarters of negative GDP. Consumer spending is in the tank. National debt is on the rise. The US money supply is greater than it's ever been. Consumer sentiment is all-time lows. The Fed balance sheet's not looking too good. The US dollar is weakening. Fiscal expenditures are high. Inflation rates are starting to change. And then debt is just off the charts. Not from a fiscal prudent standpoint, looking again globally, these are real graphs, not the best picture. So our economic curve clearly is troubling, and we're not, it's very hard to predict, but it's going to take some time for the globe, not just the U.S. and certainly not just the New York, New Jersey area, to recover economically. These negative indicators on all these charts interconnected don't go away that fast. And so we're certainly have put ourselves in a very, very challenging position to try to recover from all of this. Next slide. And just to demonstrate the impact, so as we get into the conflicting forces, as we increase containment to try to lower the mitigation of spread, which is necessary, the corresponding negative impact that has on the economic policies and the recession itself. So the more we contain, the worse the recession gets. I think everybody on this call today probably realizes that and knows that, but sometimes the pictures help drive that home. I am not a proponent of saying that we should not have instituted those policies. Because we are so low on that learning curve, because we are so low on the response curve, we had no choice. The only thing we knew was isolation, mask wearing, hand washing, but quarantining and isolating and minimizing contact between individuals was the only tool we had to deploy to slow down the spread of this virus. And so we did it. And locally and in different areas, by doing so, and I've said this before, we have saved thousands of lives. There's no doubt in my mind that those very challenging and difficult decisions that obviously have other consequences helped mitigate and save lives at the time. The challenge now, though, is that was a moment in time, and we should be further along on those other curves. And the reality is that because we are globally interconnected, when you go back to that first curve, the volume curve globally, we didn't do it, and we have not mitigated the global macro curve. And that is very important to keep in mind. So we can do little things, they are temporary gains. And that is kind of what we're seeing now globally. We isolate, we quarantine, we get short-term gains, but at some point, that's not going to be the policy that is going to get us through or eliminate this virus in our communities. Next
Thank
slide.
you. I'm just going to do the second polling question. CARES Act created a new employee retention tax credit, ERTC, for employers. Has your organization filed for the ERTC? All right, 20 more seconds. Okay, I'm going to close it out. And here are the results. Looks like 27% of you voted no. Okay, and then Mike, a good question to come in. Is there any silver lining to this crisis?
There is. I think we've accelerated. While we're low on that learning curve, there is an incredible focus to it, and so I think we're going to come out of this much better than we were before. I do think there's a whole host of things. One of the highlights for me, believe it or not, in the lowest times, when PPE was at its bottom and hospitals were struggling to get that in, the collaboration and the support that arose amongst otherwise perceived competitors was tremendous. And I've said this before, I will say it again here. I hope it is something that is not just forgotten and dismissed too easily, because we proved that when our health systems, public and private, collaborate and cooperate and work with each other, the effectiveness of us providing services to the community is amplified exponentially. And we saw that in the sharing of resources and the communicating regularly around the learning curve of what we're seeing. You know, do you prone patients on ventilators? The fast and rapid sharing of clinical information changed very quickly, much more so than would otherwise normally occur in how we responded to this virus. It made providing care significantly better. We can learn from that, and we should continue to do that. The FDA shortening their approval process and the emergency use authorizations that are coming out. Re-examine that and say, how do we now accelerate our learning curve in terms of new production, and how can the FDA still serve a vital role, but not be a blockade and a hindrance to innovation and accelerating new design and new innovation. It's one of the areas that, again, I'll talk about in a little bit, but Holy Name has incredible partnerships with our friends in Israel, not just Shara Zedek, but Sheba and others. And Israel has a much more robust, dynamic, innovative environment, and they encourage it, and from a government and a policy standpoint. And so they're ahead of us in a lot faster design and rollout of sort of new innovative ideas as to how we care for people. And I think you're going to see that here. And so there is a tremendous amount of silver lining in this, and there's others that I'll talk about in the next two slides. We can go there. So on the response curve, again, we're still relatively low. PPE now in the beginning was very difficult and challenging, and so we've gotten through that, and U.S. manufacturing is kicked up, and so at the current moment, at least for PPE, there isn't a shortage. There seems to be a steady supply of that. Ventilators as well. But in the beginning, it didn't quite work as well, and so we adhere to old policies and old design, right? Stockpiles, national stockpile. We have N95s in the national stockpile. We have ventilators in the national stockpile. Conceptually, at the time they were designed and rolled out, probably a good idea. Functionally, didn't really work well. So most of the N95 masks that we received from the national stockpile were so old and outdated and not maintained in environmentally controlled areas that when you went to put the mask on, the mask itself just simply shredded and wasn't much use. The ventilators that we received, most of the plastic circuits on those ventilators were dried and cracked and unusable. And some of them were so old, it was almost impossible to find replacement parts to get them functioning. And so the stockpile is a good idea in theory, but in practice, it needs significant improvement. I actually think if we can gear up to better surveillance, which I still think we're way behind on, and respond quicker and ramp up emergency manufacturing, that is a much better approach than creating and storing on national stockpiles large inventory that's not going to necessarily be maintained. Again, use of monitors. So whether it was pulse oximetry that was obviously needed, and thermometers, there was digital thermometers, there was a shortage of those in the beginning. Cardiac monitors for these patients, so there was absolute shortages there. The use of negative pressure industry-wide, not just within an individual organization. Staffing levels and the ability to pull staff in was always a challenge. Diagnostics, reagents, even as of today. So we have lots of instruments, and we did great on manufacturing the instruments, but to gain readily access to reagents to run those instruments and run high volume real-time testing is still, even today, a challenge. And then we have what I will call the academic response. So in our response to this, if you look at the US health system, it's broken down one way of viewing it, in many ways. So one way is there are three large interconnecting circles, each with a purpose. Again, this is not a blame and this is not a criticism. It's how we are designed. And all I'm saying is that we should take some time to pause and rethink some of this. So we have a public health sector that works and through the government kind of on its own. We have it within the provider side. It is split between the academic side, which is where we do clinical research and we do studies, and science follows a certain methodical, well thought out approach, but it is time consuming and it is not always accurate, and it is can fall prey to subjective influence as opposed to objective science. And we saw that a lot here. And then there's what I'll call the street medicine. And the street medicine is the ERs and the ICUs, the physicians and the nurses and the caregivers who are really on the front lines, who have to deal with everybody coming in through the front door. And we saw that here. We saw when there was challenges to a patient's viability in the early days, when testing was 7, 9, 10 days out because of its availability, and someone would come in symptomatic. Staff here and elsewhere, this is not unique to Holy Name, I heard this across the board, those frontline staff became so good at observational diagnostics. It is a lost art where they could actually look at somebody and know they were COVID positive, even when the test came back COVID negative. And so we would treat them as COVID positive because the tests were not as accurate in the beginning, and there's still some deficiency there. It's not as accurate as people would like it to believe, but it is what we have, and it is still very, very good. So I don't want to, again, anybody to misconstrue what I'm saying there. But observational diagnostics, that's street medicine and how we respond. And so in the middle of a crisis, when you don't have the luxury of time and you have to respond, we have to tune into those individuals. We have to put them front and center. And the academics and the public health people who are not on the front lines need to take a little bit of a backseat and let the frontline people voice what they see, and we have to give them the respect and the dignity of listening to what it is that they have to say. Next slide. So the final one, we wouldn't be a Catholic hospital if I didn't hit you with a little bit of the moral curve, and we saw this throughout. So one of the things that I had seen, I did not figure this out on my own, published early on, was when you break down COVID-19 into its component parts. Co is a prefix meaning joint, mutual, common, or together. Vid is Latin for to see or look or to observe. And then when you sum the digits of 19, you come up with 1. And so when you put that all together we see as 1, or the common observance as 1. And I think what this is kind of ironic is what COVID has shown us is, as a global humanity, we are incredibly interconnected and interdependent on each other. If you think about it, that my health and my preservation is dependent on your actions and your responsibilities, and vice versa. Nothing greater came out of this than that in COVID, and we saw people rise to that. We saw in March and April when we put out the request, and the governor and others to shut down. People were observant, and people were compliant with that. We saw the positive rise of the healthcare workers and the heroes across the board who stepped up in just incredible ways to care for their fellow man. That's a lot of the silver lining in this, and we saw that. We also saw the worst of humanity, and we saw those who tried to profit and hoard PPE and the other components that were there. We saw the politicking of this throughout the country, which to me is disgraceful. We saw a lot of misinformation and a lot of pandering of stuff. And so the moral curve is not a straight curve, and we hope it is that arc that goes to justice in the long term. But in the short term, it is a very erratic, and we see both the positive and the negative components of humanity. And that came out pretty strong through this crisis. Next slide. And again, just to drive home that interconnected, we are one interdependent world. We have a tendency here in a nationalist kind of a way of thinking that we are immune from the rest of the world. We are not. And if anything that this virus has proven is that we are a global society now, and that this virus spread because of that. And so what happens in Europe and what happens in the Pacific Rim and what happens in other components of this world are just as vital to us as to what happens in New Jersey or what happens in Philadelphia or New York. And we always have to stay tuned to that. That is a new norm. That has all been the norm for a while. This crisis has accentuated that. That has massive implications for how we conduct ourselves, how we perform, how we monitor, how we respond. It is not something that should be minimized at all as we move forward. Next slide. So for me personally, many know this hit home literally. I was diagnosed with the virus on March 17th. I can say what I said earlier, and I'll repeat it again now because I violated this, so I can say it out of shame and humility. I was not honest with myself when I was feeling sick. I felt the pressure of needing to be here. That was foolish. That put people in harm's way. That came back to roost with me because I managed to infect my entire family. I have 4 sons and a wife, a daughter-in-law, 2 soon-to-be daughter-in-laws, and I managed to infect all of them. My one daughter-in-law was pregnant. She ended up giving birth 6 weeks early to my grandson in June. So you need to heed that very, very seriously, and know that if you don't feel good, had I acted prudently and intelligently at that time, I probably wouldn't have infected my family, and we would have been able to take greater caution to mitigate that. I am fortunate that I wasn't hospitalized, where I was able to stay at home thanks to technology and telemedicine and telemonitoring. So I was instantly hooked up to our telemedicine telemonitoring program here. It worked quite well. There was one night where I was asleep because fatigue for me. I never had a fever. I never had what I would call severe respiratory distress. I absolutely had severe fatigue and weakness. I had chills early on. I had that now very dominant loss of taste and smell, but for me mostly taste. So those symptoms were very, very real. And there was one night when I was home and I was asleep and my pulse ox slipped down to 88. And one of my nurses called because they were monitoring me and said, Mike, it took me a while to respond because I was asleep. And they said, get up, reposition yourself, move. Let's see if we can get because if you don't, we're sending an ambulance and you're going to have to come in. And by getting up and being able to move and reposition myself, I was able to get my oxygen levels, my O2 levels back up to a more normal saturated rate, and was able to hold off the ambulance coming. So it does work. And I think that is also a silver lining in that we have now, and there's a couple of slides coming that will touch on this, we have broken the glass ceiling on telemedicine. It is here to stay. It is going to grow exponentially. It is a huge patient satisfier. It is a huge, very quick response. And most of all, it is a way of keeping people safe. We can go to the next slide.
Okay, we're just going to do our third polling question for this session real quick.
Sure.
Okay. Do you feel that your organization currently has adequate resources, including personnel and monetary resources, to meet their cybersecurity needs? All right, about 15 more seconds. Okay, I'm going to close it out. And here are the results. So 68% of you voted yes. And a lot of questions have come in. We have time for a couple more. Are hospitals really safe for non-COVID patients?
Yes. And I think what we saw early in March and April here in New Jersey specifically is when we shut down all other services, there were some very drastic unintended consequences there where people were dying at home because they were too afraid to come into the emergency rooms when they were having strokes and cardiac events and other issues. And so I think it is critical that everybody realize that not just Holy Name, from what I know as an industry, the hospitals right now, I would argue, are probably the safest place to be because we are so tuned in to what this virus is, how it's spread, and what precautions we need to take to keep our staff and everybody else healthy. And so I would argue, do not put off any care. You can be treated very, very safely and very efficiently by coming in. And so hospitals are safe. Hospitals and the personnel have the resources now. Like I said, the PPE is not a shortage, and we know what we're doing. And so please do not put off care. There's no reason for people to be alarmed about coming into the hospitals.
Okay, and then a couple more. What is the future for healthcare and COVID?
Could you repeat that?
What is the future for healthcare and COVID?
So the future for healthcare and COVID, I think, is going to be around technology, telemedicine, telemonitoring. It's going to be around re-examining our facilities to be much greater in terms of infection precautions. There's a couple of slides coming where I'll talk about that, using ultraviolet lighting in our HVAC systems, in our sterilization, looking at antimicrobial, antiviral fabrics, not just silver washed types of rinse, but actually fat fibers that are infused with antivirals and antimicrobial product that are going to comprise everything from bed linens and sheets to scrubs and gowns and clothing throughout the organization. So there's a tremendous amount. And then again, technology, the application of technology, whether it be video, audio, remote monitoring kind of capabilities, is just going to, I think, explode and prove that we can be much more agile, much more responsive to larger segments of the population when we adopt some of these new technologies.
Thank you. And then final question, and then about 5 more minutes. Were you afraid that you might die?
Actually, I was. So there were, when I hit the low point there was a couple of days where it was, I will in all honesty tell you, I was a little scary. And so I was worried. I prayed often. I was concerned. I am an individual who never, ever, ever gets sick. I can't remember the last time I was sick. That arrogance led me to be in a state of denial when I was sick, because I had 9 million other excuses. I was working late, I wasn't eating, I wasn't working out, I had all sorts of other stresses going on. But yes, this is a virus, as I had said early on, and I'll say it again now, as it is upticking. It needs to be taken very, very seriously. You don't know, and unfortunately, we don't know, right? I do not know why I recovered. The best physicians I know that I've talked to globally do not know. They cannot isolate and pinpoint exactly why I or my family recovered. Why do young people not even really feel the disease? My sons, when they had it, my younger sons, they had it for 2 days. They were basically fine. To them, it felt like a bad hangover. For my wife and I, it was debilitating at its lowest point. I couldn't even, I remember thinking it was smart to take a shower, a hot shower, try to revive myself. Well, hot showers drain the oxygen out of your system. I almost passed out and had to lay on the bathroom floor for about 2 hours before I could even get up. That's a scary thought, and not one that I've ever had in my life. And so please take it very, very seriously. So what we did here is, again, when we shut down visitors and restrictions, but that led to change in adoption of technology, which actually proved to be a big satisfier to people coming in. So you now get scanned and screened and have a temporal read. We know that this is not as clinically precise as we would like it to be, but behaviorally, it has a huge impact. And it tells the community when they're entering Holy Name that we care about you and we're taking precautions to safeguard you and everybody else. So please step up to the monitor, get scanned, wear a mask before you come in. We then also adopted self-service kiosks, very much like the airlines. And so I think you're going to see a transformation. This has been going on for years at a very slow pace. I think it'll accelerate exponentially now in terms of self-service kiosks, kind of like going to the airport. You no longer have to, it's all self-service. Well, registering to come in to visit at a hospital or to set up online ahead of time is all going to become more self-service, automated, and again, a huge patient satisfier. So these adoptions were necessary out of the crisis. They will be permanent going forward because the visitors and the patient satisfaction is so high. Next slide. I mentioned earlier that because of a lot of the innovations here in our Institute for Clinical Research, our simulation training. So our Institute for Simulation Learning was always, for the past decade, partnered with Messer, the Israeli Center for Medical Simulation, which is part of Sheba. We are now officially part of ARC, which is Sheba's program for Accelerate, Redesign, and Collaborate. Sheba is a big believer that healthcare lags in the application of current technology and learning in terms of accelerating and redesigning. And the best way to do that is through collaboration. Those are 3 pillars that Holy Name stands on as well. And so we're real honored to have been asked to partner with Sheba in accelerating that here in New Jersey. Again, telemonitoring, I talked about this, but it shows you the effectiveness as to how it works and the efficiency. We did over 25,000 telemedicine visits. At one time, we had simultaneously over 5,000 people being monitored and cared for using this technology. So they're ill, they're sick, they're at home. They're not putting others at risk because they're isolated and quarantined. And yet they have the access to our professional caregivers, and they have access to real-time vital sign monitoring for our caregivers to be able to help coach them through those points. And if in fact they do crash, that we could deploy our ambulance squads very quickly and get them in. This proved highly effective and efficient. And when you get into a highly contagious disease, this kind of hospital at home model is absolutely the wave of the future. Next slide. Again, our Institute for Clinical Research took off in this. Holy Name has over a dozen clinical studies and trials going on. We were the first in the world to use Pluristem with great success. It's a placenta cell. We were the first in the world to administer Regeneron to anybody. And so we participate in a whole host of clinical research. I said earlier, the FDA and the acceleration using the emergency use authorization has proven extremely beneficial and I think productive, and should be something that everybody considers making permanent, or at least refining from the crisis, but it should definitely not go back to what it was. It should be maybe some hybrid in between, but it should be open for exploration. Next slide. Again, some of the things that are going to change. This is how negative pressure works on a typical unit, but most of our Holy Name's an old facility. So most of these patient rooms have solid wood doors. That doesn't work in negative pressure. And so we've embarked on a renovation throughout, and every door is either going to have large window panes cut in for visibility and preservation of negative pressure, or we're going to change them out totally to glass doors with privacy glass to increase vision. We're expanding negative pressure throughout. I mentioned earlier about our mass casualty modular design. Looking at all non-clinical space, auditoriums, large conference rooms, other areas that could very quickly and rapidly be converted to clinical space in the event of an additional crisis. And so that's all part of our emergency preparedness now, much more so than it was in the past. And then a little item that we experienced here, and many did, because of all the ventilators and because of all the high flow oxygen, we were freezing up our main oxygen lines because of the use. And so when we opened our Marion Hall critical care, we actually had to backfeed and put in a secondary oxygen source, a temporary one, a tank on a trailer to feed that, so that we weren't freezing up the lines. We are now going to incorporate a secondary oxygen source as part of our overall facility planning going forward, so that that's always there and we're not dependent on the availability of a portable tank. Next slide. Again, redesigning the facility using negative pressure everywhere. That'll become permanent without the tubes hanging out the windows. UV lighting in the HVAC systems, in individual room sterilization. There is the concept of far UVC continuous lighting. So it's a different frequency UVC that you can actually be exposed to. When you use the high intensity UV lighting, like in the one picture on the upper right corner, you cannot be in the room for that. You will get worse than a suntan. And so you want to look at how we can have continuous UVC. Looking at copper surfaces for antimicrobial and antiviral surfaces throughout, not just on doorknobs and everywhere else, converting them so that the infection spreads. And then, as I mentioned earlier, the antimicrobial and antiviral fabrics. Next slide. Again, changing how we terminally clean rooms and response throughout, whether it be in the OR or any room or any treatment area. Adopting all this new technology now will become the norm going forward. Again, we're going to advance our technology using pan tilt zoom cameras everywhere, hands-free voice, remote bedside monitoring, and personal devices for our staff. One of the nice things and advantages that Holy Name has is agility. We are one of the very few hospitals left in the country. We actually still write our own software, and we do a lot of our own information system design here. Our EMR is our own. We can plug in with anybody and anything else, so we're not as Epic or a Cerner shop. That allows us to very rapidly deploy a whole host of real-time improvements. We did that here in terms of our own surveillance, our alerts to caregivers and areas when things were happening, and just increases our own overall patient and staff safety. So changing information systems, deploying information systems, using this kind of technology that we're meeting with today will all become part of that norm for the future, and should be widely adopted and accelerated in its adoption. So that kind of concludes. I want to just thank everybody for your time today, for listening to our story. There's a lot more, obviously, but this was sort of the highlights of what's there. This YouTube video, that link on the bottom, and the slide deck is available to you, is just myself and my facility director going through explaining to people, because we were both surprised at the response here around negative pressure and how to quickly do this. I think one of the tenets for Holy Name, and I'll leave you with this thought, is we welcomed and we're extremely appreciative of all the support we got from NJHA, from the state, from the governor, the commissioner of health. It was greatly, greatly appreciated. But one difference, we weren't going to approach this and be dependent on it. Early on, we said, we're in the middle of this. We have to figure it out for ourselves. We have to be responsive. A lot of that came from our training in Haiti, where resources are scarce and you have to be able to innovate and on the fly to provide care to hundreds of thousands of people. A lot of that training came into effect here. And so we're appreciative that nowhere, past, present, or future, do I think there is discussion or time in this for blame. We're in a crisis. It requires fast and rapid decision-making. Mistakes will be made. If you look at this objectively and not cynically, we can be a lot better and a lot more improved and a much more efficient healthcare system as a result of this for decades to come. And I hope that's the takeaway from today. So thank you all for giving me the opportunity to share our story. I appreciate it very much. Scott, it was great being here. Thank you.
Michael, thank you very much. That was simply amazing. Incredible story, incredible keynote address. Thank you very much. Our most sincere thanks for sharing your story, how it affects you individually, your family, and the Holy Name community as well. With that, and we appreciate it as well with the look to the future of healthcare and COVID, and some great comments. I thought your various curves that you showed and shared with the audience as well was really, really tremendous and very informational. Thank you very much for joining us today.
Thank you. Thank you, guys. Appreciate it.
And with that, we're going to transition now to our first panel. The panel addresses the financial aspects of the COVID-19 pandemic. I'm pleased to introduce the moderator of this session, Dominic Segala. Dominic is principal here at Withum and market leader of Withum's healthcare advisory team. Dominic has extensive experience in healthcare finance and consulting, including finance, operations, strategic planning, revenue cycle, affiliations, and consolidations of facilities. Today's panel includes Sean Hopkins, Ryan Kennedy, Gail Kozla, and Charmaine Spence Rochester. I'm pleased to introduce Sean Hopkins at this time. Sean is the Senior Vice President of Center for Health Analytics, Research and Transformation, CHART, at the New Jersey Hospital Association, where he is responsible for overseeing all analytical modeling, both financial and statistical, on behalf of NJHA and its members. Ryan Kennedy is the Executive Vice President and CFO of Holy Name Medical Center, where he oversees the hospital's financial, accounting, and budgetary functions. Gail Kozla is the Senior VP, System Financial Operations and CFO of the Central Region of RWJ Barnabas Health, where she leads financial operations for the system, as well as works with strategy and finance in building models and executing plans to achieve the system's overall and Central Region strategic financial goals. She also serves as the New Jersey Central Region liaison to the Department of Health for the COVID-19 response. And Charmaine Spence Rochester is the CFO at Penn Medicine, Lancaster General Health, and until just recently, she served as the CFO of Chester County Hospital, Penn Medicine. In these roles, she ensures the hospital's financial integrity, while also overseeing the organization's fiscal services, revenue cycle, and patient access professionals. I'd like to welcome everybody here this morning. And at this time, I'd like to turn the program over to Dominic Segala. Dominic, it's all yours. Thank you.
Thanks, Scott, and good morning, everybody, and thank you for joining. And just a thank you to Michael Maron. That was really just a great keynote to kick this off. With me today, as Scott said, I have 4 great panelists, And we're going to focus on the finance aspects of this pandemic. And we're going to really talk about everything from supply chain to lessons learned and to the future and what really this looks like in 2021. So it's so much to cover. I'd like to get started right away, and I'd like to take this back to the beginning and really talk about in the first 3 months of this pandemic. And I think a nice continuation from the keynote is to focus on, and we'll kick it off with Ryan, in terms of the supply chain. And everyone heard about clearly the issues around the supply and demand, right? Great demand for the N95 masks, for the ventilators, limited supply. You had price gouging, you had fraudulent companies, you had all kinds of issues to deal with. And Ryan was right at the epicenter of this, and Michael even mentioned it. So Ryan, if you could kick this off and really talk about how you and your team in the beginning of this pandemic really worked through these difficulties around the supply chain.
Sure, Dominic, happy to. And unfortunately, I could provide countless examples. I'm sure many of my colleagues who work in the space could as well, in dealing with bad actors and price gouging, especially during the first few months of this. So as Mike mentioned during his remarks, we were hit pretty early, along with all the other hospitals here in northern New Jersey and in New York City. And we found out pretty quickly that even the best prepared were woefully unprepared for what was coming. The inventory of PPE we had went quickly. Like Mike mentioned before, some of the supplies we got from the stockpile were expired and unusable. And our traditional suppliers were equally unprepared and simply couldn't provide to us the supplies we desperately needed. So that led us to look for alternative sources for PPE. And unfortunately out there, some saw this pandemic as an opportunity to turn a quick buck. So as many could probably attest to, and when going through similar experiences, it seemed back in March and April that everyone we talked to, be it doctors, board members, friends, family, people concerned, knew a guy who knew a guy who get supplies, often from China or Taiwan. And a lot of people were actually running businesses who couldn't manufacture and had supplies, were actually getting offers from suppliers in China promising N95s, gowns, masks, gloves at various prices, various quality. A lot was unknown. And a lot were good intentioned, but there was very little vetting that was going on. So that really put the opus on us to do our due diligence and really make sure that we were getting what we were getting and what we were expecting to get, because all this was being promised as long as we wired money up front and it could be drop shipped overnight to us. Wow. So in general terms, price gouging happened pretty much overnight. So supply and demand, like Mike mentioned. So something like an N95 mask that traditionally runs about 75 cents per piece went up to $4, $6. And at the worst, we were being asked $10 a piece for a mask. Surgical masks that generally are a dime a dozen, all of a sudden went up to $1 for a box. So the price gouging was pretty rampant. One example that sticks out in my mind about price gouging and potential fraud came actually very early on in March, when we were scrambling really each day to find adequate equipment for our staff, even shift to shift. I mean, we were begging, borrowing from our colleagues, anybody who had an extra box of PPE or gloves. We would happily go over it and get it and then return to them when we got more supplies. In this one example, like many of the other examples, the lead came through a member of our medical staff who knew a guy, not just any guy. This guy was a big time importer exporter who ran a Turkish company. It was a paper company when we did our due diligence, but they had a supply of the coveted 3M N95 masks, not the KN95s, the real deal, that were held here in New Jersey. He had a stockpile of millions sitting in the free trade zone in Elizabeth. And we thought, well, this was great. We could go, we'd get the masks, and we could even partner with our neighbor hospitals to get a huge order of millions in. The price was a little rich, $6.50 per mask. So we were being gouged, but we were desperate. So we pursued it. The problem is, at this point, we learned that we need to see the product first, because what they're promising is a 3M N95 was often a KN95, which at that point we didn't think was safe for our staff to wear in COVID areas. So we asked, could we see the product? The answer was no. We would actually not even be let into the free trade zone in Elizabeth unless we provided proof of funds through a letter of credit up front. And not normally dealing with letters of credit, we contacted the bank, did our due diligence, and found out with a letter of credit in these types of international transactions, the bank has very little leverage to say no once we authorize them to issue the letter of credit. Thereby, if we show up and find out the product is not what we asked for, they could still force the bank to pay. And we were talking about upwards of $7 million for this order. So at that point, we got cold feet and actually asked the governor's office to get involved, because if they truly were sitting on a stockpile of millions, maybe they would have some success of either cutting a deal themselves or getting these N95s released. And immediately, this guy from Turkey disappeared, the stockpile disappeared, and that was the end of it. So that was just one of many, many examples I'm sure everybody else on the call could share. But that's essentially what we're going through, is literally day by day trying to get adequate supplies at a reasonable cost.
And Ryan, thank you. And that's, I can't even imagine trying to go through that when the importance of the PPE and protecting your frontline staff is the #1 priority at that point. You know, and during the beginning of this pandemic, and everyone knows the draconian impact it had from a financial standpoint on the hospitals, to the point where, you know, we saw a $1 trillion CARE Act, unprecedented, that Congress put out. 175 billion of that was for the providers and the hospitals. To date, 140 billion of that has been issued, and another 100 billion of advanced loans for Medicare. So there was 240 some odd billion dollars as a cash lifeline put out into the providers across the country. But what I'd like to do is take this back a little bit more locally and talk about the impact in these early stages of the pandemic that this had on the hospitals of New Jersey, and with the cancellation and deferral of all the elective surgeries. And there's no one better to discuss that than Sean Hopkins. So Sean, if you could give us and shed a little light on that for us, that would be great.
Sure, Dominic, thank you. Yeah, you know, I mean, obviously, you know, hospitals we're kind of, you know, cruising along. We go back to 2019, which is pre-COVID. You know, hospitals in New Jersey were running at, you know, roughly a 4.3% positive bottom line. Some hospitals were actually in excess of 10%. Some hospitals were slightly negative, but for the most part, on average, we're about 4.3%. So, you know, I mean, as you would expect, COVID had a devastating impact on hospitals. You know, to put it in perspective, New Jersey hospitals are roughly a $25 billion a year industry. So that's about $2.1 billion a month in revenue that would ultimately be generated by hospitals. In the first several months of the pandemic, you know, we saw essentially a devastating impact to the hospitals. Hospital revenues fell approximately 32%. That converts to about $650 million a month, and that was largely due to the suspension of elective procedures. The governor issued Executive Order 109, and what we found was that, you know, hips and knees and bariatric surgery, those things that would normally be coming into the hospital, were no longer permitted. You heard Mike Maron talk earlier about the fact that unfortunately some people were staying at home, afraid to come into the hospital, but elective procedures wound up being down in April and May. We saw that elective procedures were down about 91%. You say, okay, if there was a ban, why not 100%? If there was an emergent situation associated with the need for that elective procedure, you were still allowed to go ahead and have it done. But essentially a 91% reduction in elective procedures. And even as we went past the ban on electives, we started looking at data in June and July. Elective procedures in June and July of 2020 were still down about 25% over elective procedures that were being performed in June and July of 2019. So even though the executive order, the ban was lifted, there was still a negative impact. So, you know, if we look at those 2 months, if we look at March and April, or April and May, when the ban was in effect, revenues are down $650 million. We also identified that hospital expenses were up by about 12%, or $215 million a month. What were the added expenses? overtime pay, combat pay, greater reliance on agency staff, and purchasing PPE, not only at elevated quantities, but elevated prices. You heard Ryan talk about all of the wheelers and dealers that were out there that were willing to sell you and all the PPE you wanted, and you were just going to have to pay a price that was just through the roof. So you add all this up, if you look at a $650 million drop in revenue on a monthly basis, you look at a $215 million increase in expenses, you put those two together, you got $865 million impact a month on $2.1 billion in revenue. So yeah, it's so what was the end result? As I mentioned earlier, I said, hospitals in 2019 had an operating margin of about 4.3% on average. We're looking right now actually at a preliminary third quarter FAST report. For those in the finance industry, you're familiar with our financial analysis and statistical trends report. We call it the FAST report at NJHA. And it looks like through 3 quarters of 2000, we have an operating margin of about -0.5%, -1%. About 40% of the hospitals are operating in the red, but more importantly, the statistical side of that analysis is illuminating. Year to date 2020 over 2019, inpatient admissions are down 7.3%. Outpatient activity is down, outpatient visits are down 19%. Emergency department activity is down 25%. People are still afraid to go to the emergency department. And Dominic, you mentioned in the beginning, you talked about the CARES Act money at the national level. Let's bring that down to New Jersey. New Jersey hospitals, received the lion's share of the CARES Act money that came into New Jersey. It was roughly $4 billion. I can tell you that most of that money, in all likelihood, has already been brought into the hospital's financial statements. And so that negative margin that we talked about includes an infusion from the federal government of close to $4 billion. It is significant help, but it's crazy to say it, but it's not enough. And the Hospital Association have been talking with our representatives at the federal delegation at the national level. We're in conversations with the American Hospital Association. We're hoping that there's going to be another stimulus package. We hope there's going to be additional money because I think that drop off in electives, I think all of that is still, especially as we start to see a surge, start to see the hospitalizations start to go back up. I think there's still going to be attrition and erosion in terms of the amount of hospital activity that exists, and it's going to continue to have a debilitating impact on hospital financials.
Yeah, and thank you, Sean. And we're going to touch on a little later too about potentially more stimulus and the need for that. And as everyone was aware, in the beginning of the pandemic, the focus was New York and New Jersey and the Northeast per se, but also the bordering states. And I'd like to hear a little bit from you, Charmaine, how the impact it had at Penn and also your other hospitals that you speak with in Pennsylvania, to really hear how that impact affected you. And also, if you could just shed a little light on how your staff, you and your staff adapted, right? A lot of people had to work remotely. If you could give us a little insight on that, that would be great.
Sure. So I'll start off by saying that one of the things that the pandemic highlighted for us in Penn Medicine is the importance of systemness, because we were able to see what was happening with the hospitals in New Jersey, specifically our sister hospital at Princeton, and learn from them. And so as Princeton was going through the height of the crisis, the hospitals in Pennsylvania were learning from what were the needs, how, what were the critical supplies we needed to secure, what was happening with staffing, what did we need to do with services. And so we learned from Princeton, and at the same time, we had the ability to provide support and resources and really operate as a system. I think in many ways it taught us what systemness really means and maybe helped us redefine what that meant, and the agility of being able to allow decision making to happen at the facility level when needed, but at the same time have coordinated resources and activities across multiple hospitals. And there's a push and pull between those two things, as the facilities needed to be agile, but at the same time the system needed to provide some high-level support to make sure that if we needed to move resources from one spot to another, we could do that. So I think we learned a lot from what was happening in New York and New Jersey and Pennsylvania, use those lessons to prepare. We didn't see the surge happen quite the way it did in New Jersey at the time, but I think those lessons probably are coming in handy right now. I started as a CFO at Lancaster General on Monday, and this region is one of the hot spots right now in Pennsylvania. So we're taking all the lessons that we've learned from our colleagues who have been through this and try not to recreate the wheel. I think one of the differences right now for us, though, is trying to manage the care of non-COVID patients. Initially, back in March, we shut down all elective services, and you know, we can't afford to do that. And so we're having to learn how to care for COVID patients safely while providing care for other patients who need care as well. So that's a little bit different, but that's part of the dynamic of what we're dealing with right now.
I'm just gonna, oh, sorry. You can keep going. I thought that you had finished.
Yeah, go ahead.
I just wanted to launch our first polling question for the session. What are the biggest challenges to your organization? Great, 20 more seconds. Right, I'm gonna close it out, and here are the results. So 32% of you said technology refreshes. Sorry about that, Charmaine.
No problem. I'll just answer the second part of Dominic's question about, you know, what did the finance and accounting staff do? And similar to the pivot that our clinical teams had to do, a lot of our support services like finance and IT and rev cycle had to also pivot fairly quickly. I remember the Friday in March, I think it was March 13th, when we called the team together and said, we prepared to be offsite starting Monday. We didn't know how long. We honestly thought it would be maybe for a month or so until, you know, things calm down, and it has turned into folks are still working from home. So across Penn Medicine, I think we still have roughly 15,000 people who are working remotely of the 40,000 workforce. And so we're relying heavily on our IT professionals to make sure that we have the connectivity for the network and the new tools that we're using now, because prior to the pandemic, we would have in-person meetings and maybe we would have conference calls, and now it's all about Zoom or Blue Jeans or Teams. And so our IT colleagues are working to make sure that those tools are available and accessible for us, so that we can work seamlessly. And as we look to the future, I think this is one of the areas where, as health systems, where we traditionally expect this in-person culture where folks are in an office, in a building, or in a hospital somewhere, I think this really gives us the opportunity to think about where the workforce needs to be and what that looks like in the future.
And thanks, Charmaine. And that's a really good point too about the IT. You know, they're always behind the scenes, but without the work they've done, you know, we wouldn't be on this call today and be able to pivot as quick as we did. And Gail, I'd like to turn it to you. So we've talked about PPE, we've talked about, you know, many of the issues in the beginning, everything that people have read about, the unfortunate, you know, severity of the illness. But I'd really like to get, from your perspective, a little bit behind the curtains, if you will, some of those problems that you encountered that probably the normal person didn't even think about, and how you kept things running other than those items that we've already discussed, because I know there's probably many of them out there that we didn't even think of.
Thanks, Dominic. Yeah, I think the big area, and Charmaine touched on it a little bit, is the IT component of that. And I think, you know, while, and I look back in this and think about if this had happened 25 years ago or 20 years ago, it would have been a whole a completely different story with the lack of technology that changed so much even in the past couple of years. But I think from an IT perspective, capturing the data was really a big effort, and the data was important. And I think that we were sort of hit suddenly in terms of the type of reporting and the type of data elements that we needed in order to advise on resource needs internally in the organization, and also in collaborating with the state and other hospitals within the state, the Department of Health, the Hospital Association, working together, also reporting to the federal government on the availability of PPE, availability of important life-saving equipment like ventilators, staffing, case counts for resource funding. So all of that was really critical to not just the outside reporting, but internally managing our facilities and making sure that we had the data and that the data was correct. I think that IT did a yeoman's job of standing up systems very quickly. And there was a lot of work going on behind the scenes in terms of verifying that information and trying to get, in some cases, manual data on a daily basis of what was available. Counting masks, counting gloves, and making sure that our hospitals had enough supplies to meet the demand that they were seeing, on an ongoing basis. Ryan talked a lot about procurement of those supplies, but then there's the whole issue of distribution and making sure that everybody's got what they need on hand and that they're not hoarding and things like that. And then some of that data also went into advising the state as to availability of ventilators that they received from the federal government and then were deployed throughout the state to various hospitals. We talked a little bit about information about staffing and where were the staffing needs with respect to licensing level and who could provide care for our patients. From the nursing end, from the physician end. And so the data was really, really critical. I think also on the IT side, and Charmaine touched on this, the remote working environments, we weren't really used to working remotely, and some of the important processes, I know payroll is an important process for every finance area, but the functionality of that working remotely isn't something that is tested on a regular basis. And I think that it really opened our eyes to how we have to be prepared in the event of an emergency. A different emergency might come down the pike, and we need to be able to maintain connectivity to the important workflows. I think we mentioned staffing, but alternative staffing capabilities was, I think, another thing behind the scenes. Hospitals working with the State Department of Health on various waivers to ensure that we had enough staff to care for the patients. I think that was a really important collaborative effort.
And Gail, you come from a large system, and the North and the South as it's segregated. And the North clearly in the beginning was hit harder. Were you able to share resources and pull resources from your Southern hospitals to assist up in the North?
Yes, I think on the inventory side, we manage our inventory collectively across the system, warehousing that and distributing that. So we were able to use stockpiles of inventory to help supply our hospitals across the state. And I think most importantly, really the learning involved in the care treatment plans, and that we had a regular couple times a week discussion with all of our leadership across our system to talk about those care protocols and different resource needs across the system.
Great.
Hey, Dominic, can I just jump in here real quick and just piggyback on what I was just talking about? I wanted to just maybe, just elaborate on, data is I don't want to say data is power, but data is insight. And there was a real thirst for what the heck is going on out there right now. We needed to kind of get a general sense of what the landscape was. So one of the things that we did, and I think Gail alluded to it, was we at the Hospital Association built a data portal. and hospitals were required to, the governor actually passed an executive order saying the hospitals were required to submit data to that data portal on a daily basis by no later than 10 p.m. every night. We were collecting case counts, bed availability, vent availability, PPE inventories, staff shortages, and then discharge activity. And when we were rolling all of that up into a daily dashboard, feeding that to the governor, to our member hospitals, to the commissioner of health, all to inform decision making and collaboration. You heard Mike allude to the fact during his presentation about business rivals all of a sudden started to collaborate. Who needed what, where, and when. All that information was value and kind of guided the decision-making process. And that's not going to, that need for data is not going to stop anytime soon. So I know it's a huge undertaking for the hospitals to get it in there, but it provides more value than you could think.
Yeah, and I think the biggest part of it, really from a financial end, was that the funding came from that source of that same information. So, ensuring that that data is accurate, and as Sean mentioned, daily, it was a lot of work to do, but critically important to every component of the operation.
I just want to jump in real quick to do our second polling question. What do you feel is your organization's biggest security risk? $20 more seconds. Okay, I'm going to close it out. And here are the results. 33% said employees. Okay. Thank you.
Thanks, Rachel. So at this point, we talked about the beginning stages. I'd like to turn it back to, the current. And Sean touched on it a little bit, but a real interesting report came out yesterday that basically took the information for the first 9 months of 2020 versus 2019 for 900 hospitals across the country. And really the numbers were staggering, and they somewhat are in line with what Sean had discussed, but 16% decrease in adjusted discharges, 18% drop in ED visits. And again, this is 900 systems across the country. So your volume's down. Many of the urban hospitals, when ED visits are down, clearly 50 to 60% of your admissions are going to come from there. So your revenue is going to drop. Then you have the increase in expenses. And what it said was a 19% decrease in margin from the first 9 months of this year versus last. And that is with all forms of relief funding. Without the relief funding, a 72% drop in margin. And that's just detrimental to the industry. And Sean, I'd like to turn it back over to you a little bit. And I know you touched on the recent FAST report. If you could just elaborate a little more on that and what you see going forward also, because I spoke of it on a national level, and if you could bring it back to a local level again.
Yeah, maybe just to talk a little bit about the activity. When you think about a bell curve, we kind of went up in April and then down. So it's got peaks and valleys. And you can see that we clearly now are actually headed towards a second peak. First hospitalization of a COVID case in New Jersey was on March 4th. Every time I say this, it always blows my mind. 6 weeks later, April 14th, 8,200 COVID patients or PUIs, persons under investigation, sitting in a hospital bed. To put that in a little bit of perspective, there are about 18,500 beds. Hospitals have ramped up a little bit, more capacity, but normally it's about 18,500 hospital beds across the state, running at about 65% occupancy. On any given day, you're going to have about 12,000 patients sitting in a hospital bed. So think about a statewide hospital industry that's got 8,200 COVID patients occupying their bed capacity. That to me is significant. When we scroll forward, we go to July and August. And all of a sudden, the hospitalizations are down to about 400 to 450 on any given day. So I'm sure a lot of people were thinking it's over, we're out of the woods. But as of this morning, I can tell you that there are confirmed positives in PUIs totaling 3,288 in hospital beds, and we're kind of like on a stepladder approach now, where it's starting to continue to go up. Daily positives, about 4,000 to 4,500 people in New Jersey a day are testing positive. The transmission rate, every time somebody gets infected, how many people are they going to infect? You want that to be below 1. In July and August, it was 0.96, 0.94. A few weeks ago, it was high as 1.3. And now we're sitting, I think about 1.16 was the last that I saw. And the positivity rate's over 10%. So second peak, winter surge, twindemic, whatever you want to put a tag on it. It's absolutely definitely happening, and it's absolutely definitely coming. But there is some good news that we are gleaning from our ability now to look at data. Back in April, if you were admitted to a hospital for COVID, you had a 1 in 4 chance of not leaving that hospital alive. Death rate was 25% for hospitalizations. That's now closer to about 6%. The average length of stay was about 9.5 days. It's down to about 6 days. We're seeing far fewer patients require ventilation. In the beginning, 25 to 30% of patients being admitted to the hospital were immediately put on a ventilator. We're down to about 10 or 12% that are requiring ventilation. So, you can absolutely see, that we're not out of the woods. And just to kind of go back to the peak and talk a little bit to what Gail was alluding to earlier with data. There were hospitals that were at 100% ICU capacity. Every single vent in the facility was being utilized. Hospitals were looking into try and put multiple patients on a single vent. How can we re-engineer a vent to have it support multiple patients? We seem to be beyond that now, probably in all likelihood, because the hospitals have learned. I think Mike had a chart in there that had a little curve. It said, in the beginning, inexperience, and then in the middle, you're gaining experience, and then you've mastered it. So I think the hospitals have learned what the appropriate protocols are to treat the patients. And so from that perspective, going into a hospital if you need to is the right place to go. But, we are wary of the hospitals being overrun and ICU capacity starting to run out again. Right now, this events seem pretty plentiful. But ICU capacity is ticking up, and now that Thanksgiving is just coming gone, we have more holidays on the horizon. Right. I think the numbers are going to continue to rise.
Yeah, it's a scary time for sure, and some great points you brought up. And Gail, I'd like to turn it back to you. The first time around, there was no playbook. Sean just spoke about we're almost back at or where we were in the beginning stage of the pandemic from a number standpoint, albeit the acuity might be a little less in the ICU. What will you and your team do different this time around? What did you learn from the first time, and how are you preparing for this second wave, if you will?
Yeah, I think as Sean said, there are a lot of things that we know now that we didn't know then. I think, the care treatment, access to testing. We had way back, we had a lot of patients that were under investigation. Now we have a quicker turnaround of testing and better ideas of what the symptoms might look like. And so we're more refined in terms of who we think is actually has a potential for being positive. So that's better. The medication availability is great. I think, some of that has been part of the federal relief program. Some of that will have to be paid for in the future, but we know how to treat it. And so the technology aspect of that is better. But as we go into this next phase, as Sean mentioned, all the models that you look at, the projection models, say that this is going to be worse because it's coupled with the flu. Right. On the tail end of the holidays, where people are not socially distancing as much as they should be, and so we're seeing those higher volumes coming. Everyone believes really now that the issue is going to be with staffing and not with supplies as much, and availability of staff. in particular because now the rest of the country is seeing the pandemic at the height of what we saw. We were sort of isolated geographically. And so some of those resources that we had, and we had federal resources in some cases with the field hospitals, those resources are elsewhere in the country. So I think that is an issue. We're also dealing with staff fatigue and resiliency issues about just coming off this pandemic, and now they're having to deal with it again. And then also the vaccine is out now, or it's going to be out. And so we're planning for how we are going to administer the vaccine. In some cases, we're using the same staff to administer the vaccine that we need to care for patients. So I think that's an issue. And we talked a little bit about services. So the elective services are back open at this point. And we'd like to keep them open, and not just for financial reasons, but also because people delayed care. And in some cases, patients died at home because they were so concerned about coming to the hospital emergency room that they put off coming in. And so we don't want to delay care. We don't want to delay those screening tests and things like that. So we want to try to keep that open. So that's a challenge. And I think just also dealing with new business models, telehealth, things like that are taxing on the resources of the hospital. So we're ready, but I think these are new challenges that we'll have to deal with on the second go around.
No, and it's that mental health and fatigue, and everyone's trying to get that PTO in around the holidays and stuff, which makes it even more difficult. What I'd like to do now is just switch gears a little bit and talk about cyber and the cyber attacks. And cyber has always been a threat in healthcare, as everyone well knows. The PHI, the medical record, is such a complete record that the hackers try to take that and they can easily duplicate and make a name from that record. And unfortunately, in the past 3 or 4 months, these attacks have increased, and you've seen in the news some very large, well-known systems have crippled them for 15 days or so. And to the point where the FBI came out about a month ago and gave a warning. And whenever we think of a cyber attack, whenever I do, you always focus on, clearly it's going to be downtime, you're going to have no software, no automation. And the focus, rightfully so, is on the quality, patient safety, quality care of the individual. But I'd like to shift it a little bit and talk about what impact this has on keeping the cash spigot running. Because if you really think about this, if we look across the 3 systems we have right here, it could be anywhere from $1 million to $10 million a day. And when systems go down, in terms of how do you get that authorization on the upfront? How do you drop the bill that's normally sent out electronically? From a scrubber standpoint, from a medical record standpoint, how do you overcome this? But what I'd really like to focus on is how do you prepare for something like this? And it's been a while since I've been on the provider side. We always used to call it downtime procedures. So Charmaine, I was wondering if you could just talk about if and how you are preparing for the unfortunate if a cyber attack does occur from a revenue cycle standpoint.
All right, sure. So I'll start by saying I think our best defense here is to try to prevent it from happening to begin with. And I know that Penn Medicine is putting a lot of effort and focus into trying to identify where threats may occur and trying to stop it before it impacts our system. I think we've deployed over 35,000 endpoint CrowdStrike protection and to 35,000 of our endpoint users, with so many people working remotely. And over 1,500 servers also have that. We have restrictions now on what folks can access when they're on the network. So personal webmail and Google Drives have been not allowed anymore. We've disallowed folks to connect to devices like that. And I know that there's continuous monitoring to make sure that if there are any threats showing up, we catch them before they become a problem. One of the other strategies they're using is they're doing their own testing of phishing. And if some, they're educating employees, especially those who are working remotely. And if someone does fall prey to a phishing email, then they have the opportunity to educate the staff so that hopefully in the future, if it's an outside threat, it would be caught timely. But from a revenue cycle perspective, I think because we're an Epic shop, that we certainly have downtime procedures and downtime devices. I think it does help that Epic is a cloud-based product and it's housed somewhere else. And so if there were some impact to our revenue cycle, I think it would be an inconvenience. I don't know that it would cripple us completely. I think just the backup procedures that they have would be inconvenient to deploy, but certainly would keep things going. And I know that our accounting and payroll are also cloud-based products. And so if something bad were to happen to the systems locally, there's the opportunity to get back up and running without too much downtime. So I think trying to prevent an attack is where the focus is, but we certainly have the processes in place to be able to get back up and running if something did occur. And there's less concern about totally crippling the system.
No, and that's a great point, and you're fortunate to have the ability to have everything in the cloud, and it's really those smaller standalone facilities that could really be struck and really have a detrimental effect from some of these cyber attacks that are happening. And Rachel, would you like to put in the third polling question?
Yep. All right, so a third one for this session. Does your organization perform security awareness training? Twenty more seconds. All right, I'm going to close it out. And here are the results.
Great.
Okay, thank you.
So it appears yesterday, as I was reading through some literature last night, that there was a little bit of progress from a stimulus standpoint. And I don't know if that means, McConnell and Pelosi actually returned each other's texts from a few weeks ago, but there was 50 bipartisan people came together from each chamber. And what they're talking about, now nothing's been submitted, is about a $900 billion package, $100 billion of that for the healthcare entity and healthcare providers. $30 billion for tracing and for testing, another $30 billion for the providers to be determined, but the language did talk about further expansion of virtual care and telenetwork, et cetera. And then two important things that I thought were a short-term to be defined moratorium on any liability or malpractice cases during this period of time. And the great takeaway for me, and we've been discussing this for some period of time, is a potential 50% forgiveness on the $100 billion of the Medicare advanced loans. So basically what they've discussed, again, hasn't been put through Senate, is to forgive or convert 50% of that $100 billion in loans to actual grants. But with that being said, and Ryan, we started with you, and I'd like to get your outlook on what you see for 2021, your hospital, and the importance of a third fiscal stimulus package and the impact it would have or would not have on your facility in terms of, if something did not come through, how are you looking at 2021?
Right. So with that said, the way we look at 2021 continues to evolve, right? As we're in the very beginning stages of what seems to be a second wave. So all the budgeting that we've done up to this point, pretty much we can throw out the window, because you can't accurately forecast even everything we went through last spring. This second wave isn't even occurring the same way that first wave did. And to couple that, and jumping on something Gail touched on earlier, we're not going to be able to rely on traveling nurses and others to come and help staff our units, should the second wave be as bad as some predict. So with that, even if the governor doesn't step in and shut down elective services, we as a hospital might need to make that decision for ourselves. If we need to staff an ICU full of COVID patients, well, guess what? We're going to have to shut down our ORs, IRs, all the elective procedure rooms just so we can staff those units. And that, as Sean pointed out, has a detrimental effect on our finances. Without those elective services, our revenue will continue to drop. So even when we were planning on a 2021 budget, looking at things like when did OR cases return to normal? And was that more pent up demand, or is that true normal, or areas like the ER, which still hasn't recovered? Going into 2020 was already an impossible task to budget for, and then here comes the second wave. So the short answer is yes, additional provider relief funding will be necessary. It was necessary in 2020 to keep us all afloat, and it will continue to be necessary as we get through this second wave well into 2021 as they're predicting. So I think the CMS forgiveness is a great idea. The money's already out there. It's in all the providers' coffers. It's sitting there. We just need an act of regulation to make that happen. New provider relief would be fantastic. However, I would also point out that the existing provider relief, if they would just finally make up their mind on how we can actually use the money, that could be another potential source of funding for the hospitals, because many hospitals are looking at this like, hey, I can't even submit a FEMA claim based on these new rules and regulations. There's other source of funding available. And while other providers that I've talked to are planning on having to pay some of that back based on the guidelines that are currently out there. So while new funding would be great, if we could just look at some of the rules, regulations around the existing funding that's already out there, that could be a potential source of funding to get us through this second surge.
Yeah, and that's a great point, Ryan. I think we could spend a whole nother hour just talking about the reporting requirements that are coming upon us pretty quick, and some of the just scratch your head at some of the ways they have those rules and regulations, but the FAQs come out daily. For the last 10 minutes, what I'd like to do, and maybe Ryan, we'll just continue on with you, but maybe just for the audience, just some lessons learned, some recommendations, and some best practices. Maybe if each of you could just take 2 minutes from what you've learned during this whole 9-10 months and what's going to unfortunately continue.
So lessons learned is kind of to expect the unexpected, and when it comes to questions of finance, the answer always needs to be yes. So you have to do whatever you can to support the clinical staff, do whatever they ask. We need to be available, even pulling some of our resources to do things like help out in the cafeteria. Anything where we're shorthanded, if a certain area gets impacted and staff gets sick and not there, we need to be ready to step in and help. So just be prepared, do what you can, and help support those on the front lines.
And maybe we'll just go in order of how we're shown on the screen. So Gail, if you want to just continue on.
Sure. I mean, I think one of the things I learned or got proof of is that necessity is the mother of invention. And I think that, we saw some really creative solutions to a problem that a lot of people didn't know an answer to. So I think that that's a really important takeaway. I think we've got a lot of really smart people in the industry. And with them all working together, I think that we, really stepped up to the challenge. And I think we'll continue to do that as we get into this next stage. I really have thought highly of the collaborative efforts of the Hospital Association, the Department of Health, other hospitals who, and I think Mike mentioned this in his talk, how we work collaboratively together to come up with solutions. And I think that really is a testament to our industry.
So I just want to echo what Ryan and Gail already said. I think as finance folks, we have to remember that we're here to support, especially when we're in a crisis mode, our clinical leaders and those who are having to make tough decisions in the moment, life and death decisions. And we should be enablers and not stand in the way of those decisions being made. We also need to continue to be innovative. I think the crisis proved that necessity is the mother of invention, as Gail said, and we just need to continue that. And the only thing I'll add is I think in the midst of crisis, there's so much negativity around us, and we can see all the bad things that have happened as a result of COVID. but it's important for us to maybe step back and think about maybe the good that has come. And it doesn't take away from the fact that it has been, really, really tough for so many people from a health standpoint, financial, social. But there's also good, and I think we need to try to find that good, focus on it, and practice gratitude as much as we can so we can stay resilient and lead our teams through the next wave of whatever is coming with this crisis.
And Charmaine, that's a great point, because really one of the keys is, I've always said, healthcare was 10 years behind in technology, and it's really accelerated to the point where virtual care is here to stay, and CMS will keep the rates where they are because the patient experience will never go back to the way it was. And Sean, if we could just finish up with you, that would be fantastic.
Yeah, one of the things that I learned is, you need to be agile. You need to be able to morph. You need to be able to re-engineer as needed. Those are kind of like the lessons learned. I go back to the beginning. It was a little hairy. I mean, we're involved with data and interacting with the state, and so it was 12 to 14 hour days, 7 days a week, and I felt bad about calling one of my staff at 11 o'clock on a Saturday night because there was something that needed to be taken care of, or trying to run somebody down at 6:30 on a Sunday morning. But what I used to say to my staff was, you chose a career in healthcare, and now more than ever, you are needed. I said, take pride in your work. I said, patients are benefiting from what we're doing. And I think that got us through some sleepless nights. So those are some of my key takeaways.
And that's fantastic. And I'd just like to take a moment to thank all four of you for participating. I know everyone has such busy schedules. And thank you so much for your time on this, and have a great rest of your day. And Scott, I'll turn it back over to you.
Great. Thank you, Dominic. And thank you all the panelists. Really a terrific job. Thanks so much. At this time, I'd like to turn it over to Haley Schulman from Withum Smith & Brown. Haley, it's all you.
Hi, thanks, Scott. I thank you all for being here. First and foremost, again, thanks to our first panel for a really informative discussion. I'm Haley Schulman, Senior Manager with Withum's Healthcare Services team, and I have the opportunity to introduce our second panel, which will address Board of Trustee and governance considerations for multi-entity healthcare systems. The moderator of this session is John Fanberg, Managing Member and Chair of Healthcare Law at Brock Eichler. He has over 30 years of experience in health and hospital law, with an emphasis on corporate transactional regulatory matters for physicians and healthcare institutions. A recognized leader in the sector, John is known for excellence in transactions, perseverance in deal making, and strength in corporate and regulatory matters. Our panelists include David DeSimone, Matthew Dunan, Sonia Lawrence, and Matt Rogers. David DeSimone is the Senior Vice President of Organizational Transformation and Chief Legal Officer at CentraState Healthcare System, where he works with leadership in developing the system's initiatives and strategy. His responsibilities include legal, governance, compliance, risk management, insurance, strategic planning, as well as business growth through the development of joint ventures. Matthew Dunan serves as the General Counsel of Inspira Health. Matt has more than 14 years of experience serving as in-house counsel to hospitals and healthcare systems, including Trinity Health and Cooper University Health System. Matt is responsible for the overall direction, leadership, and executive management of all legal affairs at Inspira. Sonia Lawrence is the Senior Vice President, Enterprise Chief Compliance Officer of Thomas Jefferson University and Jefferson Health, where she leads the development, implementation, and evaluation of policies and practices designed to support problem solving, informed decision-making, innovation, in order to empower every member of the Jefferson community. She has also previously served as the Assistant U.S. Attorney for the U.S. Department of Justice. And Matt Rogers is the Assistant General Counsel at Geisinger Health. Matt focuses on managing health system mergers and integrations, joint venture contracts, and implementing strategies on fraud and abuse, regulatory and privacy compliance issues. And with that, I will turn the program over to John Fanberg to begin.
Thank you, Haley. Can you hear me okay, Haley?
Yes.
Okay, great. Good morning, everybody. Thank you for having me. Scott, great program so far, and very proud and pleased to be part of today's panel on board governance and conflicts of interest. We've had a couple of great programs of panelists so far this morning, focusing on the COVID pandemic and how impactful it has been here in New Jersey. But the business of hospitals continues to go on. And our panelists here as chief counsel in their respective institutions still have a whole host of duties and responsibilities to the hospital, definitely amplified during COVID. But in terms of board issues and governance and conflicts of interest, it's an ongoing challenge for everybody. And I want to kick it off by referencing a couple of cases in the last year and a half coming out of Maryland regarding the University of Maryland Medical System and its board members, and a little closer to here in New Jersey, Memorial Sloan Kettering. In 2019, a consultant was hired to look at some of the ongoing activities among the board members at the University of Maryland Medical System, and found that there was a significant amount of ignored conflicts going on. We had payments of over $500,000 to a board member who had formerly been in the state legislature and was the current mayor of Baltimore for 100,000 self-published children's books. In addition, over a 9-year period, $30 million had been paid to a large health insurance business owned by the family of Frank Kelly, who had been a former state senator and court board member on the voluntary leave of absence, obviously. And over the 2 prior years prior to the consultant's report, approximately $7.5 million was paid for services provided by M&T Bank associated with a board member. He also took a voluntary leave of absence. The findings of the consultant was that basically the board members and management shared the responsibility for the lack of transparency that resulted in these and many other improper relationships. A new conflict of interest policy was established. A governance committee was chartered as a permanent committee of the board. A new research-based competency model was implemented to ensure an appropriate vetting process to make sure board members who had this skill set were on the board, and the chair positions of the finance committee, audit committee, and the compliance committee were held by separate individuals. I know when I first began practicing law over 35 years ago, board members were pretty much business titans of the community who supported the board, supported the hospital for fundraising, and if you could write a check, you came on the board. So in terms of this and Memorial Sloan Kettering, you also had board members and management that had other for-profit investment interests that conflicted with the missions of Memorial Sloan Kettering. So I'd like to kind of turn to the panel and to ask them, as a result of these 2 cases, what did they begin to do differently, and what was the reaction of the board members when you brought this to their attention? Matt, let me start with you, if you can shed some light on your experience as a result of these 2 cases.
Sure, thanks, John. So soon after, we became aware of the University of Maryland situation, we really took an effort to understand, precisely what was at issue there, in terms of understanding, how that organization failed to properly manage those conflicts. And immediately after that, we began an extensive review of our own conflicts processes, just to understand, to make sure that we're staying abreast of, current regulations as well as best practices in those regards. And so, we had an outside expert come in, an outside counsel, and really help us with the review. And we got a clean bill of health in terms of how we're doing it. But of course, there's always room for opportunity for improvement. So there were some findings that we said, okay, we're doing a great job, but we can always do things a little better. And so we took those recommendations and we put them forward, and we adopted them.
Sonia, what was your experience or the reaction?
Well, I think there were lots of reactions. I think one of the things, and I apologize to make sure that you can hear me. I think one of the best things that we did was take a look at ourselves, as Matt just described, and to really understand, look, we can always do things better, but now let's make sure that we're doing them with the intent to manage through our culture where does our organization want to be? And to also know that we needed to do some things over time, not just quickly say, okay, we will no longer allow X or Y. So we did reevaluate our policies. We did implement new policies. We did take a look at how many resources we dedicate to governance in general and conflicts of interest in particular. And we also realized, and this was a telling thing for me, that just having policies isn't enough. You really have to make sure that your board understands the expectations you have for them and that you also support their efforts going forward. So we are still in the process of working through what does support look like and how do we make sure that we're giving our trustees what they need.
Thanks. Matt Rogers.
Sure, I'm happy to be the second Matt, John, for this purpose.
Yeah, I realized we've got two Matts, so I'll be more descriptive.
That wouldn't be the first time. So fortunately for us, and I say fortunately because it mostly involved, luck, like a lot of these things do, but we didn't change anything that we did. We, sort of as Matt described, we didn't hire an outside consultant to do a review, but we did do an internal review. It's cases like the ones that you just described at the beginning of this presentation that are just good wake-up calls, for lack of a better phrase. They're great educational tools for board members to say, look, this is how things can get off the rails, and if you're not minding the store, things can get away from you before you even realize it. And so we used it as an educational opportunity. Like I said, fortunately for us, we didn't feel like we had to change anything that we were doing, but it just reemphasized our annual conflict process, as well as, just educating board members on why conflicts are a serious matter and why we as a management team take them seriously. The educational aspect of these cases that make their way into the media, just I can't overstate how important they're just great tools that we use. And I think board members, when you're able to sort of give them these examples, they sort of see the light, where they realize how important conflicts are and how important it is to fill out those questionnaires, fill them out accurately, and keep in the back of their minds as they move forward with board business, that conflicts are real and things can end up in the newspaper eventually if you're not careful.
David, with regard to the conflicts, what type of training and education does your health system do, or do you? Are you? How involved are you? Do you run it? Do you bring in outside people? How does your hospital manage this?
Sure. Thank you, John. We start with an initial orientation. Any person who's going to be a board member or a committee member has different subject matter orientation, finance, legal, board governance in general. And as part of that process, I've talked to them about the conflict of interest process and go through the conflict of interest annual disclosure form that we require. And then every year, we bring before the board the results of the disclosures that folks make. Most don't rise to the level of a direct conflict, but there may be perceived conflicts. And we go through that every year, from every board member to every affiliate board to every committee, so that folks really have a good understanding of it. And then every year we bring in our outside tax folks at Withum to go over the 990s, and they spend a lot of time, Scott Mariani and his team, going over the disclosures that might show interested party transactions and things like that. So we try and hit them, multidisciplinary approach.
With regard to that orientation, are you an active participant in that process?
Yes, I am an active participant in that process, both in my legal role and going through conflicts, and in my strategy role in terms of kind of where the company is headed, and how that might help them identify conflicts. If they know where we're headed, they can understand sooner rather than later, before they get too far involved in the board, that it may conflict with one of their personal interests.
Okay. Matt, with the tie, do you, all the lawyers have ties, Matt Rogers, what happened? So Matt, with the tie, what type of training and education does your system do, and how active are you in that process?
I'll echo David's sentiments in terms of, the orientation and onboarding. Specifically, when someone's new to board service in general, that's really somebody that you really focus in on and say, I need you to understand, what your service on this board really does mean. This isn't an opportunity for you to generate business for yourself. This is really, an opportunity for you to serve the organization and the community at large. And then, annually when we push out the disclosure statements, there is a educational seminar or session, I should say, that happens, during the meeting where, we advise everyone that, okay, we're putting out the conflicts of interest statements. When we revise the forms, as we did, we trained on, here's what this question is asking. And I do encourage all my trustees to reach out to me with questions as they fill out those forms, and they do. And also, if they're encountering an issue where they're not really sure, hey, is this a conflict or not, to call me, and they do. And so really it's, a continuous process where, you're getting the group involved and saying, here's the importance of, what conflicts, are and what they mean as it relates to your fiduciary obligations, but also on a more personal and individualized level with each individual trustee as the issues come up.
Thank you. Sonia, do you do anything different, or is it similar to what David and Matt had to say?
So very similar to what everyone else has said. I will add one new layer. The fact that we are virtual, I think, makes it a little bit more difficult to reach, touch, engage with some of our trustees the way we normally do, coming in and out of meetings and so forth. And so what we put together very recently, and we'll let you know how it works, is we've made some sort of testimonial videos with some of our trustees talking about their experience, what's important about their role. And then we did use some of them to talk through how easy and pleasant it was to disclose conflicts of interest and get them managed. So we think that additional layer will help us as we have limited one-on-one contact with people in an in-person way.
Thank you. Matt Rogers, over during, so everybody kind of does in the beginning of the year, perhaps there's a little bit of refresher. Clearly when people are joining, there's the orientation process. Do you find during the course of the year, things will perhaps come up with a board member and they'll reach out to you, hey, I'm getting involved in this, or this has come up, so that it shows that the educational process worked, and has sensitized the board members, and they're in more contact with you than just this once a year fill out the form. Share with some of your experience in that regard.
Yeah, John, I mean, I would say that is most likely to happen during a board meeting itself, which in our case are quarterly in person, but then they also have monthly calls. I can't think of any, off the top of my head, any specific instances where someone has sort of just reached out of the blue. It typically would just come up like during a meeting as things get discussed. A board member would all of a sudden realize, like, oh, I should probably tell someone about this, or during the audit and compliance committee meetings of the board, things will be on the agenda to be discussed, and that will prompt further discussion. I mean, my experience, I can speak for our board, and I'm sure all the boards that are involved in this session are similar, that these are very busy people. They have, most of them have day jobs, and so it's pretty unlikely that they would just reach out of the blue. But the issues definitely come up, and when they do, we're the ones that get the phone calls and the emails, and we respond as appropriate.
Sonia, have you ever had a situation where a board member is being considered, but things have come up and you've had to kind of waive that potential board member off, that this would not be a good fit for various reasons?
Yeah, I think not often, but I think we have had that opportunity. It's why we value the opportunity to engage in the recruitment and vetting process. You hand that disclosure off to someone who we're all thinking about and we're very anxious to see get on the board, and then you realize, wow, this would really not work. We can't manage it. I think that our management and some of our governance committee members are actually pleased to know that we looked at this ahead of time. And the potential trustee is also given an opportunity to hear what those potential conflicts are and why we don't think it's a good fit at the moment. It doesn't mean forever. It means for now because you're working on X or you're involved in Y. So I think it is a good opportunity to do that very early. We've done it a couple of times, and that's why I always say, hey, I'm here. Let's make sure I'm involved in the process early so that we can get that information and use it proactively to make good decisions.
David, I know you've had this role for a number of years and in multiple different settings, so you really have a wealth of experience. Do you find that you're brought in the early process, or sometimes the management or the board chairman, they believe they've done enough work, and so they're looking for you to rubber stamp it, or what, or like, so how early are you brought in when a potential new board member is being considered, or committee member?
Right from the beginning. I have the benefit of setting the agenda with the committee chair for governance. So anybody that's a prospective trustee or committee member gets discussed multiple times before they put up for potential recommendations. So I'm involved in the setting the agendas and in the meetings and the screening process. So I think that helps to have a legal perspective early on. Not to say that things don't change, as Sonia had mentioned, and maybe the reverse happens. Somebody's being considered and all of a sudden they get a new job, and now that is a direct conflict because they work for a major vendor of the hospital or something like that, and we have to work through that. But I've been fortunate being part of the governance committee process that I'm on pretty early.
Do we want to do a polling question here?
Yep. All right, our first polling question for the session. What types of processes are mostly manual for your business? All right, about 20 more seconds. All right, I'm going to close it out. And here are the results. Looks like 34% we got it figured out.
Good response. We've got it figured out. Matt, have you ever had a board member who did not want to complete the questionnaire? Conflict of interest questionnaire?
Which Matt do you want to answer that, John?
I'm sorry, Matt Doonan. Sorry.
I'll jump in and answer that question because we actually have an easy answer. We have never had a board member refuse to fill out a questionnaire. I again, chalk that up to luck, perhaps, but we've just been lucky in that regard that we've never faced that situation before.
Has anybody had that problem?
I've had them maybe not fill out an answer, which then requires us to follow up with them and ask, is this an oversight or is this purposeful? And then if it's purposeful, then we can walk through it. I think the biggest challenge is that it's pretty complex because a lot of the disclosures use the language right out of the IRS regs, and the average board person's like looking at general counsel or somebody in the company to say, what does this mean? And a lot of times I think it's more just an awareness that they might skip a question, but we ultimately make them fill it out and make them redo it every year. That's people say, what, it was the same as last year. I said, that doesn't matter. Please fill it out. Just make me happy that we're going to refresh it for this year.
Well, and to amplify on David's response a little bit, it is, again, we're using language from the 990, so it's what is the 35% controlled entity, et cetera, and we'll get that, or people will sort of gloss over it. And so I do two things. I look at the answers, and I tend to have a pretty good sense of which trustees have the definitional conflicts, I like to call them, just because they're required to be disclosed and managed, et cetera. I'll look at those, and then I'll either call them up and say, I noticed that your response here is not quite complete, and I said, this is the information that I have. So what I'll do is I'll say, this is, I'll go to our finance department and say that, in 2019, we saw that you received payments, could you just take some time to change your, response and then send it back to me? And in that moment, I do really use that as a teaching moment to help them understand that this is for their own benefit and protection. It's really more so. The disclosure step does help protect the institution, but the first person it protects most is the trustee themselves, because if they don't disclose the arrangement, and there's later agency action from the IRS related to that, they could be subject to intermediate sanctions, which, as everybody is pretty familiar with, would mean that they'd have to refund essentially the benefit, the amount that they were paid, and then it could be subject to an additional tax of up to 100% on top of that. So I always take that moment to help them understand that I don't want that to happen to them. I'm here to protect my trustees on the board. I really, like I said, I don't ever come into the situation where they don't fill one out, but there are instances where they kind of skip over some of the questions.
Yeah, John, if I could jump in there real quick, just to add that I don't know if it's this day and age or whatever it may be, but I feel like the culture of board membership these days, everyone who joins our board anyway, fully expects to go through this process. And if anyone would object with, again, the Maryland case and the MSK case being in the media, I would think that would be a big red flag for either a potential board member or a current board member. This is just, all organizations do this. Conflict of interest 101 involves filling out a disclosure statement or a disclosure form. And I just think that it's inexcusable that someone would refuse to fill out the form and yet, remain as a board member. I just don't know how that can be justified.
John,
I think, Sonia, you were going to say something?
Yeah, I just wanted to add one point that Matthew with the tie brought up. I just want to go back to education for a second. I think that
we'll refer to me as Matthew and Matt as Matt. How about that?
All right, Matthew. So I think having the early vetting sensitizes people to the fact that they're going to be asked these questions in the future. So that's always good. I don't have any instances where someone refused. I will say it's a good means through which to check in with your trustees when you haven't heard and that they normally fill out disclosures. And I will again use the healthcare emergency as an example. I was worried because we usually do our annual disclosures around tax time. So people are thinking about it, right? So around tax time this year, people were otherwise distracted. And so when we issued our disclosures, there were people who I know are always faithful, always on time, who were lagging, not around, didn't know what to do. And so when we made those calls, I was glad to hear that they weren't significantly ill, but they were dealing with some issues that gave us an opportunity to extend the deadline, call them and say, hey, I'll fill this out with you, as opposed to you having to do it on your computer. So I think people are always willing. Sometimes you just need to meet them where they are because circumstances may get in the way of them filling out the disclosure completely.
Yeah, I agree with everything Sonia just said. I think the key there that she is understanding that these are individuals that have businesses of their own. I have board members that are, financial advisors work in the finance and banking industry. And, if you remember early in the pandemic, the markets were whirlwind and I just couldn't get them, and I understood that it probably wasn't because they didn't like being a board member. It was probably because they had large, amounts of clients that they needed to serve. So, I would agree with that. And in addition, the other thing is, during the orientation process, I think expectation setting is absolutely essential. And one of the things to consider is actually walking the new trustees through the form, at the moment they come on board and say, here's what you'll be expected to sign at the end of each year, or to review and fill out at the end of each year.
Matthew, do you, and I'll open this up, do you ask questions on the form that go beyond what the IRS is asking?
Yeah, of course. So that was really one of the biggest lessons that we got from the University of Maryland situation, was that we had an opportunity, to go beyond what is necessarily, I'll call it the conflicts for federal tax compliance, and then the conflicts for, obviously your fiduciary duty of loyalty compliance. But then there's just the optical, apparent conflicts that aren't actually conflicts but just don't look right. And that's really where, we wanted to create more of an opportunity because, if you really look at all the different levels of conflicts that presented themselves throughout the University of Maryland situation, there were some that were just completely, absolutely without question conflicts by any standard. And then there were ones that probably, they were probably okay in some sense, but the way they handled them and the way that they were sort of swept under the rug were really just, ones that, you said, okay, well, so there's a whole range of different teachings that you can learn from that. And so what we decided to do was make more emphasis around vendors. So we wanted to learn more about what relationships did our trustees and really our management team as well. I mean, that's the other part of conflicts that goes, I think, under discussed is, and I think the Sloan Kettering is a great example of that. We make all our entire management team fill out conflicts as well. But we were more interested in finding out more about the relationships of our board members and our management team with vendors in terms of, do you have family members that work there? These aren't ones that need to be disclosed on tax forms on the 990, but we thought that there was an opportunity to understand that a little more. And so that's one of the key changes we made, which is not required by the IRS. It's not required under state law, but it was something that we wanted to do to create additional transparency within the organization.
You bring up a good distinction between actual conflicts versus perceived or the whole optics with conflicts. So how do you, Matt, how do you differentiate and how do you handle the two differently?
I'm happy to say I have trustees that, they recognize the distinction and they'll say, I realize this probably isn't definitionally a conflict because I don't own 35% of this organization. But I'd love to be able to disclose this to the board and let them know we're doing it, and that was really sort of, a moment for me where, I had one trustee in particular, and he was one of my newer trustees. I said, well, absolutely, we can bring this to the board and let them know we're doing it. And that really sets a good example, I think, for the other trustees, and again, you use that moment to say this isn't a conflict, or it wasn't at the time, definitionally, because, this was, we changed our policy mid-year. But at the time we said, we're just trying to do this to create increased transparency. And this trustee, wanted to make sure the board was aware and knew about this before we proceeded to, enter into this arrangement. I think, others notice that and they start to conform to that. And then, so the board leadership sets that expectation, management sort of sets that expectation, and others begin to follow.
So my next question really relates to governance mistakes. Now, I know none of you do that at your own institutions, but I know you will read about them with regard to your counterparts, maybe within the state of New Jersey or nationally, and you learn from these. Clearly, it's a learning experience from University of Maryland and Memorial Sloan Kettering. But so, Matt Rogers, what are the common mistakes that you see that we really haven't really discussed yet? Different types of mistakes. The person, selling insurance, never telling anybody is a clear obvious one, but maybe there's more subtle or nuanced mistakes you see governance boards or management engage in.
I'm afraid I don't have a good answer to this question, but I'll use it as an opportunity to say, I feel like, you've seen one conflict, you've seen one conflict. They all come in different shapes and flavors and designs. And I mean, one thing for us is that a lot of our board members are also our patients. And not only they themselves, but their family members. And fortunately, again, we're knock on wood on this one, this doesn't come up a lot. But, if someone's not getting the appointment they think their child deserves, or there's something wrong with the care, or they feel like they haven't been cared for properly, and they sit on the board, they feel like they deserve an audience for those sorts of things, and they do. I mean, just like all of our patients do. But are we treating them differently because they're a board member? Are we treating them as a patient? I mean, those things can get really difficult sometimes. And it's gone so far as we made a change a couple of years ago to the way we handle patient refunds. And one of our board members got one of those. We're talking, refunds of co-pays, refunds of co-insurance, or whatever it may be. And one of the board members who's also a patient got one of the refunds and didn't really care for the way we had changed the process. Well, that's our process, and I, fortunately, to give this board member credit, he didn't try to use his leverage as a board member to try to get the process changed or anything like that. But when he calls, those calls end up in the legal office to deal with. They just don't get handled at the patient advocacy or the patient relationship level. So it's something, it can pop up anywhere, and you just always have to be mindful. And to sound like a broken record for the rest of the presentation, education, orientation, those things are so important and so valuable to try to head off a lot of these issues on the front end. And then those that you can't head off, you just deal with the best you can and on a one-on-one basis, and you just try to take every situation as it comes.
Sonia, how about you? You see other institutions or counterparts dealing with their mistakes that you kind of shake your head, can't believe you let that slide? Anything stick out in your mind?
So John, I'm glad you asked me, so no one can say I volunteered these things. So look, I have a lot of them, right? So let me just try to distill them. I think one is assuming that our trustees really understand what our policies say. And I'm certainly not suggesting that our trustees aren't very smart people. I'm saying they're very busy, and you hand them a paper and you think they read it, and perhaps they didn't. So just kind of making sure that they understand what the policy says and how it works in practice, I think, is one of the things that I've seen us assume that people understand, and I'm not so sure that that's true. The other thing is, I will say I am guilty of it. I don't think my panelists are, but I like to provide information. So sometimes it's unrealistic to expect trustees to read lots of the information you want to convey. Right? You give them a giant document and say, oh, I'm glad you read that. I don't think they did. And so making sure that we take the opportunity to present to them the information that we really want them to digest, understand, and ask us about, I think, is a mistake I've made, and I've learned to be better at that. And then number three, and this is a sort of selfish plug, but I'll make it. I think organizations have to do a better job of deploying resources to their conflict of interest process and to the monitoring of what we're doing around conflict of interest. If you started conflict of interest 20 years ago and you had one person doing it, you probably need more than one person today, because the complexities of it are very different. And I joke with my internal audit partners, because every year I'd love them to put conflict of interest on the audit plan, right? So just kind of making sure that you have checks and balances. We're the legal department, right? Who wants to check us? And do we really allow that checking? But some of that checking is really good and helps us to see where there are gaps and opportunities for us to be better. So those are three.
Okay. How are you, if a general counsel from a hospital in Montana calls you and they says, I've got a problem in that all the board members expect us to give them early access to the vaccine. Because as we're reading, the vaccine is first going to go to the healthcare workers on the front line, understandably and appropriately, and then where it goes from there. But do you have an expectation that board members or other VIP folks to the hospital are going to now begin to hit the hospital up for access to this? David, thoughts on that? What do you recommend to a counterpart in another part of the state? Because I know this will never happen in your hospital.
Right. Hey, it's human nature, right? I'm sure people will ask. And it's such a complex process that we're getting right now from the CDC and from the states in terms of state Department of Health in terms of prioritization, clinical frontline folks that are supporting the clinical frontline folks, seniors, things like that seem to have priority. So I think part of it is the discussion with the board up front to tell them what's going on. So we tried to kind of bring our own board along with what we're hearing in terms of the vaccines, what might be available, that we have an ad hoc work group trying to determine even within the hospital who gets priorities and what the requirements from the CDC and from the State Department of Health are. But I would say to my trustees, listen, this is your trustee. The word trust is the key reason for the trustee piece of this. And the hospital is this, community asset that if we don't create trust because folks perceive a conflict or perceive the board member getting something, out of line, moving to the front of the line when they really don't deserve it based upon the prioritization by the regulators, you're hurting the trust of the hospital. You're hurting the trust of the community. And hopefully reinforce that what their fiduciary responsibilities are in terms of helping to govern as, be governors of this community stewardship of the hospital resource. So I guess that's what I would do. Early education, reinforce what the requirements are regarding the Department of Health and CDC, and really, double down to our trustees that they have to show by example, and what they're going to do is going to make or break how people perceive trust of the hospital.
I'm going to jump in real quick for our second polling question.
Yes.
Do you have developers on staff or available? About 20 more seconds. All right, I'm going to close it out. And here are the results. Looks like 48% said no or unsure. And then we also had a couple questions come in from the audience. One is, can anyone on the panel speak about their process of obtaining information for the sixth metric for DOH's early warning system monthly report? The sixth metric now requires an adjustment for business transactions with interested persons.
Anyone can respond to that?
Hey, John, it's Scott. I'll kick that one off. Well, we've been working with our healthcare system and hospital clients with the new reporting metric actually ties in and reconciles right back to the Form 990 Schedule L, really Part 4, which was transactions with interested persons.
Right.
And I'll step back here for a minute because I've gotten some comment from some of our clients. Oh my God, why is New Jersey asking for this information? And it has to do with the transactions that have arisen with the for-profit hospital operators in the state of New Jersey, i.e. the CarePoints of the world. And as most of us know, CarePoint is a 3-hospital system in northern New Jersey. They were tax exempt, they were purchased out of bankruptcy, and they are now being operated in a for-profit manner. Well, what the state of New Jersey and others have come as a result of that is that there have been transactions with the owners of the companies, their family members, and other related companies for services allegedly or validly being provided, whether at fair market value or not, we don't know, with companies that they own or control, them or family members. And because they don't file a 990 and there hasn't been a lot of transparency, unlike most of our tax exempt hospitals and healthcare systems in the state, nobody really knows what's going on. So we believe it was an attempt for New Jersey to capture those transactions, report it in a financial metric to the detriment of those types of transactions. So what we've been working with our clients, and certainly Sonia and I have already had this conversation, and she's working on it with her team now, is to make sure that everybody understands the 990, understands the conflict of interest questionnaire, incorporating that information, and then dumbing it down to a monthly basis, because it is a monthly reporting metric. So for example, if there's a family member of a board member employed at your hospital, and that's common because you're large employers in the community, you're taking that W-2 amount and for now you're dividing it by 12, and that's a reporting metric on a monthly basis. Similarly, if there's a transaction with a board member who owns 35% or more of a company that's doing business with the hospital. For now, they've taken a 2019 dollar amount that was used for reporting on Schedule L of the 990, dividing it by 12 and reporting that now. For the month of December, which was reporting metric for November. I think it's due in 10 days. But folks like Sonia, Matt, and others on this panel are looking at the timing of completing of those conflict of interest questionnaires. Do they need to be moved up in the process to make sure that finance has the right information on a timely basis to report the metric information to New Jersey on a monthly basis? So I think that's a big consideration. When do you get them done? How often, and how do you communicate that between the folks on this panel and to their finance people who report that data to New Jersey?
Thank you.
You're welcome.
Matthew, what's the role of general counsel in hospital governance?
At least in my experience, it's really to serve as the resident subject matter expert, and that's a relative term in the sense of, I don't proclaim to be a governance expert. There's a lot of more smart people in the world as it relates to that, but to be aware of, what the current principles are and the best practices, and really be the liaison to bring those to both the board and management and say, here's what best practice says around this item. Here's the legal requirements, of course. I think those are a given. And then just, trying to be, the individual that's the voice of, trying to educate on those topics and really raise awareness for the importance of some of the features of governance in terms of, why do we do the things that we do from a governance perspective? And then just continually look for areas for opportunity. And that involves bringing in, individuals from all over the organization as well as outside the organization in terms of, Scott, and his team, they do a great job with us in sort of reinforcing those concepts when they interact with the board and with management, as well as, the other attorneys that, do work with us, and even, a lot of the, the think tanks, if you want to call them that, the governance institutes of the world, the advisory boards of the world, bringing those individuals in to help the board understand and hear it from a different voice. Quite frankly, hearing my voice drone on and on, I can understand why they might tune it out. I mean, my children certainly do, so I can imagine that. My colleagues at work sometimes could probably do the same thing, but and I'm kidding, of course, but it really is important to get others with outside expertise and from a deep perspective and to help provide those insights so that they're hearing it from different folks. And so really that's how I see the role of the general counsel, as sort of a convener, if you will.
David, how have you seen it evolve over time? Because clearly it's a new, more pronounced, it's a necessary role, it's a ton of responsibility. I know in the earlier panel, I think Sean Hopkins was appropriately saying that, obviously he's not on the front lines in the hospital, but almost anybody involved in healthcare, even outside counsel, it's a 24/7 job and responsibility, reacting to the people who work 24/7. So I have to assume you're all in that same camp too. But over time, David, how have you seen your role change and evolve as general counsel?
Sure. I think it's changed from being transactional, reviewing contracts and managing litigation, to becoming really truly a key member of the leadership team and a confidant for the board as they try and fulfill their fiduciary duties. In terms of 24/7, I think that I think the good news is that I feel like I've succeeded when a board member that doesn't have a problem reaching out to me after hours with a question. It makes me feel like we're getting through in terms of the education and the trust that we're trying to build with them. So I think it's really evolved from more transactional, hey, I have a set number of contracts I'm negotiating, to, it might be a phone call or an email from a board member saying, hey, we got this agenda item coming up. I'd love to talk to you about it, whether it be dealing with a conflict or, more importantly, just dealing with what their thoughts are and how they're going to help guide the system in terms of the governance responsibility. So I think that's really the biggest role, is more of a counselor in the true term of the word.
Matt Rogers, how about you?
Yeah, I would just add, I agree with everything they just said, so I'll just try to add something and repeat what they said. In terms of finding outside help, I think that the general counsel role these days, because healthcare is so complex and we deal with so many different issues, from fraud and abuse compliance to labor and employment to intellectual property to real estate to professional negligence, the ability to know when you need outside help, and then when you need it, which is often, finding the right help. I think that's just, I'm not suggesting I'm particularly good at that skill, but I think if you have that skill, you can bring a lot of value to your organization. You know, sometimes to the point where the board and management may say, like, why do we always need outside help? Why can't you handle these things yourselves? And the answer is, this stuff is really complex, and there's a lot of expertise that's out there. It's a struggle sometimes just to find it, or at least find the right expertise that fits with your organization. And again, you know, not putting a plug for outside counsel necessarily, but just they can bring a lot of value to the table. And John, to your question about, you know, what's the role of the general counsel and the leadership and the management of the organization, it really is just, I think a main aspect of the job is being that gatekeeper and knowing when you need the advice and finding the right advice when you need it.
Sonia?
So I would just add one thing, and I agree with what everyone else is saying. I think also the role has evolved to have a place around relationship management. And I'm talking about internal relationship management. I mean, the general counsel, chief legal officer, is a member of the executive team. And a lot of what happens with respect to keeping everyone aligned with the strategic goals, making sure we are meeting the duty of obedience with our trustees, is around managing relationships. So even if that trustee comes to the chief legal officer first, says, I've got a great plan, I think we should do this, I think we should do that, the chief legal officer can really end it there and still manage to keep everybody happy and understanding of why we will not proceed in this way, because you don't want to be in trouble and I don't want to be in trouble, and we don't need that. So I think people come to the chief legal officer, especially the trustees. Sorry that they do a lot of times, but they do. And we can really manage the relationship so that things end there and they're not calling other people to try to move forward with issues that we really wouldn't pursue anyway.
Okay, thank you. In the remaining couple of minutes, I'll just kind of ask everybody the same question. Other than conflict of interest, what would be the next big issue that you deal with on a day-to-day basis? I'll start with you, Matthew. You're doing it.
Yeah, sorry. The next biggest issue I think I see is, and there's a lot of, this isn't a new thought. There's a lot of talk, within governance around this, is preparing your board and your organization for the future. There's a lot of discussion about how do you, should you think about, a transformative process for your board in terms of elevating their performance through education, through changing, the role to be more, strictly more strategic, in a sense, in terms of really, making the board meetings, almost wholly about strategic issues that are really, fundamental to the long-term strategy of the organization, and really looking at, retaining and attracting board talent, looking at competencies that, that are on your board, trying to identify those competencies that aren't present on your board that you think are necessary to help you reach that next level in terms of the transformation, and then, attracting those individuals to serve on your board.
David?
I'm thinking standpoint of balancing, empowering, and educating the board members so that they're involved and able to make informed decisions, with the fact that they have to respect the balance or the barrier between governance versus management. I've worked for some smaller hospital systems where the board members really reflect the community. There's kind of like small business owners in the community, and they're used to doing everything in their business. So, or in their board, sometimes they want to do everything in terms of the decisions that kind of conflict with management. So, as the general counsel, sometimes it's try and kind of reaffirm, like, yes, we need you to be involved. We need you to understand the strategy. There's key decisions that you will make, like adopting a budget, adopting strategy, dealing with some of the crisis issues that come up. But sometimes I have to kind of back them down a little bit from being overzealous and maybe intervening a little too much in the management. And that's a very delicate issue. And clearly the CEO who reports directly to the board puts that person in a tough spot. So as the counselor, as the general counsel, try and be kind of the advocate for both sides to say, okay, let's try and figure out what is governance and what is management. So that's a key piece and a key challenge, I think, in terms of other governance responsibilities.
Sonia, your thoughts on that?
So I agree with Matthew and David. I would just add one other, and it's probably just a reiteration of what Matthew said. So I think determining what kind of board you need for the strategic goals of your organization. Where does your organization want to be? Who are they saying they are? What are our mission, vision, and values? And then who do we need to sit on our board of trustees to help us get there? So recruitment, I think, is a very, very complex thing. And when you're looking for people, it is sometimes difficult to align who you want with who you want to be. So I think just really stepping back and putting that strategy into place is something we often talk about doing, but we may not always put our resources there to get it done.
Thank you. Matt, I'll give you you have the last word on this.
Sure. Well, other than conflict of interest, John, we spend the majority of our time on when it comes to board governance is what all three have said. It's that, as David described it, the barrier between the role of management and the role of board leadership. It starts with setting the agenda for the board meetings ahead of time and what we think needs to go before the board and what doesn't. And sometimes that's not always clear. But really, it becomes stark when you're in the board meeting. And as David said, we've got the same kind of board members. Some love to be involved, and they want to be involved in everything down to the minutiae of the decisions being made. And we have other board members who are very strategic thinkers who have interest in the day-to-day management of the organization and want to think long-term. It's just, it's a balance, it's a struggle, and it's one we spend a lot of time on. But as Matthew started the conversation, there's a lot of value the board can bring to strategic thinking in the future of the organization. And the more you can get the board focused on those topics, the more productive the board meeting itself will be. And the more, I think, even it's helpful to management to understand what the board's expectations are so they can do their job, which is day-to-day management of the place, keeping the lights on. We really do spend a lot of time on that.
Great. Well, I really want to thank you all. I appreciate your time. Matt Doonan, Sonia Lawrence, David D. Simone, Matt Rogers, for your participation today. Really appreciate your time. I want to also thank Scott for all your work in organizing today's program. And most of all, Rachel, for all of your help in organizing it and the detail associated with it. You always put on a Class A program, and appreciate the opportunity to moderate today's program with our learned and well-experienced General Counsel.
Thank you so much, John.
John. And Scott, thank you.
We're just going to do our last polling question real quick before moving on to our student panel session. That is, does your organization have Microsoft Office 365? All right, 20 more seconds. All right, I'm going to close it out, and here are the results. It's like 72% said yes.
Okay, Scott, back to you.
Scott, looks like you're muted.
Scott is thanking the panel, especially me.
We cannot hear you, Scott.
Scott, I'll pick it up. This is Michael Saluco. Good afternoon, everybody. While we have our third panel join and our second panel drop off, let me just introduce myself. I am a partner and a team leader in Withum's healthcare audit practice. On behalf of Withum Smith & Brown, I'd like to thank our moderator, John Fanberg, and all of the panelists for a terrific discussion. Governance issues and conflict of interest are always a high priority and top of mind for our clients, as well as regulators in the healthcare industry. So thank you all very, very much. Our third and final panel session will focus on the future of healthcare, including workforce considerations and behavioral issues as a result of the pandemic. Our moderator of this session, Mr. Joseph Chirichella, President and CEO of DeBoer Heart and Lung Center. Joe has been at DeBoer for 40 years, holding a variety of positions, and started in his current role in 2010. He's played a pivotal role in developing several affiliations and joint ventures, bringing value and needed healthcare services to the DeBoer community. Our panel includes Alan Beatty, Kathleen Bennett, Clayton Fitzhugh, Lori Herndon, and Stephanie Lee. Alan is the Vice President of Human Resources at Shore Medical Center and has been with the medical center since 1990, becoming Vice President of Human Resources in 2003. Alan's additional responsibilities include employee health, volunteers, and patient experience. He's received several accolades for his work in this field. Kathleen Bennett serves as the current President and CEO of the New Jersey Hospital Association, representing New Jersey's hospitals, health systems, and other healthcare providers that provide leadership on quality, patient safety, education, and advocacy, both in Washington, D.C. and in Trenton. Prior to being selected as CEO of the New Jersey Hospital Association, she served as New Jersey's 20th Health Commissioner beginning in August of 2015. Her previous roles allow her to promote stronger collaboration among hospitals, local health departments, and other healthcare providers. Clayton Fitzhugh is Executive Vice President and Chief Human Resources Officer at Thomas Jefferson University and Jefferson Health, where he's focused on positioning human resources to strategically align with the organization's operating imperatives, delivering results, and ensuring Jefferson is poised to recruit, retain, and develop a highly talented and diverse workforce. Previously, he served as Executive Vice President and Chief Human Resources Officer at Trinity Health. Lori Herndon is President and CEO of Atlanticare Health System, where she's responsible for the health system's strategic growth, operations, and development. Not too much to say there. She's committed to listening to, learning from, and collaborating with patients, staff, the community, and all stakeholders to build healthy communities. The clinical, business, and community partnerships she's fostered to address social determinants of health have led to best practices in healthcare and have gained national and international attention. And Stephanie Lee is the CEO of Tower Behavioral Health, a joint venture partnership with Tower Health and Arcadia Healthcare. Tower Behavioral Health is a 144-bed inpatient facility with a variety of outpatient services. Stephanie provides executive leadership to the facility's operations, performance, and employee, physician, and community engagement. Stephanie has been in the behavioral health industry for 15 plus years. At this time, I'd like to turn it over to Joseph Chirichella to begin our final session. Joe, it's all yours.
All right, thank you, Michael. I want to thank our attendees for hanging in for this final panel. I think you'll see when we're done that Withum saved the best for last, just saying. Okay, in this final session, we'll focus on the impact of COVID on the workforce and what the future may hold. At the onset of the pandemic, healthcare organizations were besieged with significant challenges. These challenges spanned every facet of each organization. The healthcare workforce was especially hard hit. We did receive a lot of support from the New Jersey Department of Health and the New Jersey Hospital Association. We thank them for that support. I would also be remiss in not commending the healthcare systems and hospitals in the state for unprecedented collaboration in getting through the first wave of this pandemic and looking forward to that teamwork in getting through the second wave. Teamwork in healthcare has always been recognized as an important dimension of our success. And for our first panel question, please share with us some examples of how your team have risen to support each other to get through this challenge. I'll invite Kathy to respond, followed by Stephanie, please.
Good morning, and thanks, Joe, and the folks from Withum for working to put this panel together, and frankly, this entire conference. The conversation has been incredibly interesting today, and of course, the topic is absolutely on point as we start to see another surge or reemergence of COVID here in New Jersey. What's kind of interesting is NJHA, recently celebrated its 100th anniversary. And when we were formed, it was back in 1918, which was the year of the Spanish influenza pandemic. So I'm hoping that it is another 100 years before we see something similar. And one of the things I found really interesting is that I think it's fair to say that, what was the greatest challenge of a generation in 1918 is very similar to the greatest challenge I think we will see in the generation today. NJHA, I think a lot of folks know, has a really dedicated emergency preparedness and response staff. And we are well prepared in activating an incident command structure that has staff from a huge variety of areas. They come together in a coordinated and an integrated response. It's an interesting period of time when we do it all hands on deck at NJHA. All of our different departments come together because we each play a role in helping to craft, and architect an environment that supports the type of response that was needed across the healthcare continuum, and frankly, out into the broader community continuum and business continuum. One of the things that I would say I thought was really interesting as we were moving forward is that our core team, which had about 15 people on it, met every single morning, 7 days a week, to support our members. We did things from lending critical expertise and support to our members. We did the same thing to the New Jersey Department of Health as the incident commander for the pandemic response. And we also coordinated with our public health partners. One of the things that I thought was fascinating to watch is the level of integration between what happens in the public health and the emergency response environment with day-to-day hospital operations. We'd only seen little glimmers of it with the response, for example, to Superstorm Sandy, but we saw the full force and effect of I'd say a healthcare system that has such an investment in the community that it serves. And you could see that from the types of expertise that we provided to our counterparts at the state level, and that each and every one of our hospitals provided to their communities, to their mayors, to school districts, as they were trying to sort their way through the pandemic. And the types of things that we did really embraced that mission of supporting our healthcare system so we could protect the health and well-being of the people of New Jersey. And I looked at what our members did. They came together with us at NJHA, challenging this pandemic and coordinating in 35 different calls a week, where they could, one, support each other, and that's really important from a resiliency perspective. So sharing what those common experiences were, particularly in the beginning, where this novel virus had no real information on how to diagnose and to treat. And then they started to emerge into these calls where innovations and informed best practices took precedence. And we started to refine what to do for diagnosis, what to do for treatment. And that started to be shared in such a collaborative environment. And it was probably where we saw New Jersey as a healthcare team coming together in a way that wasn't related just to facility and not just to system, but to a broader enterprise overall tied to this mission of improving the health of the people of New Jersey. So I would say, we've discussed the challenges, the solutions, the lessons learned, and that's been incredible for our healthcare organizations, but it's also been incredible for, the folks at NJHA as we continue to work through the types of waivers and other permissions that were needed to execute on the strategies being developed and, to help facilitate the writing of this playbook on pandemic treatment, pandemic diagnosis, and pandemic response.
Stephanie, your thoughts, please?
Yeah, hi, thank you. Thank you for having me. So Tower Behavioral Health, we have this very unique experience where we're a brand new facility and we opened in the middle of this pandemic. And in doing that, it was really all boots on the ground to get a hospital up and running. So that included both non-clinical, clinical leadership, direct care staff really coming together to have our facility open and operating, and everyone really had to support one another. I'm proud to say that at least I didn't hear it, but I never heard anyone say that's not my job. We had non-clinical staff supporting the clinical teams, and just small little things that, for instance, non-clinical staff took over doing the employee screenings at the front door so that the clinical teams could be on the floor with the patients. So just little things like that that we deployed were really helpful to our clinical staff, where they felt extremely supported during this time. Another thing that we did similarly to Kathy is we have a COVID command center and we meet on a daily basis. And in an effort to not saturate our employees with information, we generate a weekly communication out that really touches on multiple facets. And we also make information readily available to our employees via their shared drive. We have a 24-hour COVID hotline. So all these things that we've put into place so that people feel as they know we're being transparent. They feel like they have the most up-to-date information. And so they feel safe and they feel supported in being here, operating and providing care to the much needed behavioral health population that we serve. Additionally, another thing that we did is we, as many organizations have, we have an employee activities committee. And this committee has been very robust during this time, because one of the things that we found is that, this not only is operating in COVID a challenge on our employees, but they're serving a behavioral health population that's very vulnerable. And so their job day to day is a very hard job. So deploying this reward sort of programming and this way to give back to them, we have found has really boosted morale, and they feel supported and appreciated. So our employee activities committee is charged with, at minimum, once a month providing an event or giveaway. But what we found is it's actually happening multiple times per month, that they're, having some kind of small activity that's safe, socially distanced. They've gotten very creative in what they've done to appreciate our employees. And being a part of those events and hearing our employees and seeing them feel appreciated has really helped to keep them going through this really hard time. Getting a behavioral health facility opening during COVID was a big challenge in and of itself, and they've done a really good job. So we found that really appreciating them consistently has been very helpful.
Thank you, Stephanie. I believe there is general recognition that this pandemic has stressed our workforce both on the job and at home like never before. Many of us historically have had assistance programs to support employees relative to behavioral health and financial issues that we've even further enhanced since March. Unfortunately, even when these resources are offered on a confidential basis, employees hesitate using them for fear that their employer is watching. For our next question, what creative ways has your organization come up with to promote and improve utilization of these critically needed assistance programs? If we could hear from Alan, please.
Sure. Again, thank you everybody for being part of this, and Withum for hosting this. Very, very strong program. In regards to the employees feeling that they have an avenue for them to be able to seek assistance, that's been a challenge for us. We all recognize that our employees are under so much more pressure than they've been under ever before. The normal EAP program, employee assistance program that we have in place, which we have actually seen an increase in the number of individuals reaching out to them, I'm still not sure is reaching the need of what everybody is out there. We have tried, we've actually brought our program on that we coordinate through a company called Legacy to allow them to have access to some of the counselors within the Legacy program. And early in the process, we actually had one of the providers come on site and provide some assistance in regards to in a group setting. That was actually very well intended, and we got some great feedback on that. But to be able to do that on a regular basis was just not something that we could be able to accomplish. So we tried to transition that in a way that allowed it to be online and allow people to have access. And though we offered it out in a lot of different time frames and different shifts, it really was not something that our employees, for whatever reason, felt comfortable in regards to accessing. We had participants, but not to the numbers that we thought we would have. So we kind of reverted back to trying to encourage our employees to let us know when situations are arising, let us know where we can interject. And we have a group of individuals that we've trained along over the years called our CISM group, Critical Incident Stress Management. And so when something happens in a particular area that is overwhelming, and even more so with the COVID situation, we're able to deploy the CISM group fairly quickly. And that has helped us numerous times with identifying issues at the moment they are happening. Where I still think we missed the mark is the ongoing issues that are happening out there, just the family dynamics, the issues that are happening, personally that tend to come home, they bring with them to the work environment. And we're still trying to figure out best ways and best methods to be able to address those. Still pushing the EAP as being a resource out there, and Legacy having opportunities for them to engage where necessary. Another item that we have seen an increase, we had developed what we call our Embrace Fund. This is for individuals who are having financial difficulty for whatever reason. And this is money that's donated through fundraisers within the hospital or through payroll contributions that allow us to have a fund of money out there. So if somebody has a crisis that is of a financial nature, they make an application. We have a committee that looks at it. It is confidential. All names and anything that would identify to a particular employee is redacted. But the committee looks at it for appropriateness of refund of offering assistance, and 9 times out of 10 there's an approval given, and we are able to offer money from the Embrace Fund to help them with those situations. There are small things, but they do make a difference. I think what's happening for the most part is seeing that our employees are helping each other. It was mentioned earlier that employees helping employees seem to be the biggest strength in knowing that they're there for each other to help them get through these situations. And it's not just in work, but it's also at home where they get together and they help each other as necessary, where if somebody has a situation, they can work together to help each other to get through those. So it makes me proud to know that the employees themselves are really stepping up, helping each other. Where we can, and admittedly it's still a gap, where we can help them in other resources is still something that we're trying to put together and allow them some type of access to.
All righty, Alan, thank you. Clayton, your thoughts on this, please.
Sure. Well, in healthcare, we start behind the 8 ball from the get-go, as it were, because as healthcare providers, what do? We provide care, we provide comfort, we try to provide cures for other people, and sometimes we don't see that we need that ourselves. So with that in mind, and that is the basis of where we're starting, communication is key. Thank you, Captain Obvious. I know that we would all hear that and would think about that. But we know that scientifically that people generally don't connect with something until they hear something 7 times. Well, in healthcare around this particular topic, it's not just 7 times, it's 70 times 7. And so we've got to continually be talking about it in terms of EAP and going at it about different ways. So for example, connecting it with work-life programs has been an important piece for us. So when we encourage people to talk to EAP and call EAP, it's around a lot of times work-life issues such as elder care, child care, financial help, and even legal. That's all part of that benefit. And so when they get connected and they start calling EAP for those types of things, it's just a little bit easier for them to pick up the phone and call them about a wellness or an emotional and mental need that they may have, or soul care as we would call it. And so that's an important thing. The other piece is the education around the EAP programs and what does it mean and what do they have access to really when they do that. Sharing testimonials is another important piece that we try to do and talk a lot about, to make sure that we're talking in real life terms about people that have connected and have been helped. Of course, we don't share specifics and names, but sharing those testimonials has been really an important component. And I would also encourage for all of us to think about, moving past just the EAP and thinking about our own internal facing strategy around the wellness and care for our colleagues and employees at this stage, and establishing that. And for us, we've done that in 4 different areas. We call it our pyramid, our 4-tiered pyramid of emotional and mental health. And it dovetails into some of the things Alan's talking about. First of all, that one-on-one care in terms of expedited referrals for employees to our own Department of Psychiatry within our university, and being able to get them access to that. And in HR, in the Department of Psychiatry and Behavioral Health, tearing down those silos that we had initially, and working as a team for the betterment of the whole, as it were. The 24/7 hotline, pastoral care hotline. Some people may not be comfortable calling EAP, but they would be comfortable talking about pastoral care. So we have access to that. The group services, and being able to, as a group, bring people in from our Department of Psychiatry or EAP that'll work with a team that's just had a difficult time, a traumatic loss, a traumatic event on their floor, their group, bringing them in as a group. And sometimes it's not even just that, it's on Zoom, but being able to have them interface with one another exclusive, without management in the room, and being able to talk about that. And then the self-help, and being able to get all kinds of resources similar to what Alan and Stephanie are talking about. We have a whole resource of videos and materials that they can access online. And a lot of times I'll hear people talk about they listened to something on the way home from work that helped them as they were getting ready to go into their home and connect with their family. And some of the real-time opportunities where we had the suicide of a physician in New York, that impacted our clinicians deeply here. So being able to create a video in real time that helped them connect. And so that's all part of that strategy. And lastly, I'll just say the 4th piece is building wellness and self-care, and it's part of the culture. And that starts with leadership. And so next week, for example, we have our top 300 leaders in our whole organization coming together for 2 hours to talk about self-care, family care, and how to care for your team through this. And so it starts there, and we'll just build that through the fiber as part of our long-term strategy.
I just want to jump in for our first question, sorry.
That's all right.
Okay. Have you considered the nexus implications for telecommuting? About 15 more seconds. Okay, I'm going to close it out, and here are the results. Like 40% of you voted yes.
All right. Moving along, critically important work taking care of our employees. But one lesson that is clear from the pandemic is that attitudes and acceptance for working from home have changed, and it's unlikely that we're ever going to return to on-site levels post-pandemic. So I have a two-part question for our panelists. Currently, what percentage of your non-clinical staff are working on-site in the office versus remotely? And secondarily, what are some of the obstacles you've encountered with this remote workers, both originally and now? Stephanie, please.
Yep, sorry, I had to mute myself. Sorry about that. So you know, as I mentioned earlier, we have this unique situation where we're this brand new facility trying to get up and operating. And, you know, I really had to have everyone here, both clinical and non-clinical. So, you know, back in when this all started, that was sort of our gearing up phase to get the facility open running in July. So the percentage of people that we had out was pretty much 0%. There were days that people could work from home, and based on those days, just sort of flexing like 2 to 3 days, maybe a week, that people could work from home, and that was a small percent. You know, it was a challenge for me because the biggest message was to keep people safe and have them work from home, and that was really difficult to have people here. But we, being a new organization, we're smaller. Even now that we're up and operating, and we've been up and operating for quite a few months now, we're still, because we slowly grow capacity, we're still only at 33% capacity. So we're still not at 100%. So we have a lower volume of patients. We have a lower population of employees. So we do not have as many people here sort of exposing others. And so we have sort of a lower traffic. But we probably have about 10% right now who are working about 2 to 3 days a week at home. You know, we're still in our early stages. We're a very young organization, so people are having to still work together between non-clinical and clinical departments to work out workflows, policies, and procedures. Each department is slowly hiring and onboarding new people. So through that, you know, even when it's a non-clinical department, you know, finance, business development, they're still finding that they're having to be here some on site. As we continue to grow capacity month over month, you know, our challenge is going to be then, as these departments grow and we're getting higher volume and we're getting more people here, is going to be sort of tightening up that sort of flexibility that we've had, and looking at each department and determining, you know, what percentage of time should people be working from home? Should we move to some of those non-clinical departments being at home 100% of the time? You know, but like I said, right now, you know, we kind of had this very unique situation where, you know, we had to just kind of be here on site to ensure that our organization was running safely for our patients.
Thank you, Stephanie. Lori, as a fellow member of the Southern region, maybe you can let us know what's going on in the South.
Yeah, thank you, Joe, and thank you, Withum, for hosting today. I guess I'll back up a little bit and talk about the challenges that we were having before COVID in getting our leadership to embrace the working from home, you know, focus. And of course, as the demographics of our employees have changed dramatically, that needed to be a priority, which we were not doing so great with. You know, when you go forward a few more months and we run into COVID, almost overnight, hundreds of our employees, you know, went home to work. And clearly, and I think right now we're probably close to 100% of the population that can have, if you will, have office work working from home. There is a split. We did a survey, you know, very much wanted to listen and understand what the staff felt and what the leadership felt. And I'd say not sustaining this last surge, we really had people who would have preferred to do like 1 or 2 days in the office and the other 3 days, if you will, at home. That was the preference as far as the model. Obviously, this last uptick in cases, you know, that's not as doable. So we've really been working hard to, you know, create that acceptance. There have been some conflicts. I think HR has gotten involved at times, where leaders have gotten involved, where the employee maybe thinks that they can do more from home, or feels that they're doing really well from home, and the leader either needs has a different opinion of that and needs to be either, we need somebody to come in and facilitate that discussion. So it has been a little of that. We also have spent, I'm sure like all of you have spent a lot of money and time on, putting together the desktops and all the technology that really support, being able to manage that. And then, the worry that still is out there is that engagements, something that, as I mentioned, probably before COVID, we might have had 20 people working from home. Now we have probably close to 600. So how do you put together strategies to create that engagement, especially if people can't come in? Like I said, people preferred a hybrid, but right now, we're trying to keep everybody home as much as possible and minimize, to no more than 2 or 3 people with a lot of physical distancing, but coming up with strategies to, interact, have some, downtime as far as not always, just go from one meeting to the next, have some social interactions and, be able to share some pleasantries as well as, some positive feedback for everyone. So it's been a journey. I think our younger generation who was really pushing for us to explore the working from home is much happier. I would say that some of the demographics that I mentioned before, where the people that have never worked from home had a big struggle to make that leap. And some of them have done that successfully, others not so much. I know it was hard for me. And I just kept coming to the office. I have a private office, so that was supported, but I know not everybody was embracing it at the same level. So we continue.
All right, well, thank you, Lori. And we'll explore that a little later when we talk about morale. But right now, I think we're all anticipating the availability of the vaccine, and DOH and a number of different health organizations have surveyed physicians, nurses, and support staff relative to their willingness to be vaccinated for COVID. And unfortunately, as we now know, based on these surveys, less than 50% of those asked are willing to be vaccinated at this time. So I think we'd like to all hear about what your organization is planning to do to encourage higher participation in terms of being vaccinated to protect the workforce. So can we hear from Clayton on that topic a little bit?
Sure, Joe, thanks. I think that the key here is intensive education. And I think we're doing a survey as well internally of all of our colleagues and employees. And so we'll stratify that data and learn from that, and that'll help inform our ultimate approach to this. But we're looking at a lot of education, so endorsements by respected infectious disease leaders, both externally and internally, will be important. Also, communications by our executive clinicians, researchers, and leaders, and making sure that they're out front, particularly those of our African-American leaders, Latinx, also Asian, LGBTQ community leaders as well within our own organization, to be able to talk about those and encourage around and educate around this topic. The communications team and marketing team putting together a comprehensive campaign, as you can imagine, that'll include things such as town halls and testimonials again, and try to dispel some of the myths and some of the things that we're hearing that are just out of the norm of what we would expect in this particular area. We've also made a commitment that we'll keep politics out of it. We'll keep Hollywood out of it. We're going to go internal and stay away from both of those areas as part of our effort going forward. And we'll also discuss the realities of the side effects and spend a lot of time with our scientists sharing about what we're looking at. This morning we had a meeting with our CEO and we talked about the importance of doing a video at the executive level of perhaps our CEO and COO getting their shot, but their vaccine. But as soon as you do that, you're 50% good and bad with that. Some people will say that's great. We need the leaders to step up and show that it's safe. The other 50% are going to say, leaders are taking it first, and the rest of us have to stand in the line. So you can't win in that scenario. You're going to be 50% right and wrong all at the same time with that kind of an approach. So we're still working through that, and we'll make a decision in the next couple of weeks. Lastly, I'll say the thing that we're talking about here is how do we, in this intensive education and communication effort, we spread a little bit of hope in this scenario. And what do I mean by that? We're talking about, we're within 2, maybe 3 weeks of people being able to, on the front line, start getting some vaccines and some of the vaccinations. And then, you know, a little bit after that, you know, 3 weeks and they'll get a second one. And then, and we're talking about it in terms of helping people to see that there is an end in sight. Now, we all know that that's probably still 120 days away, but we also know right now our team is weary, and we're looking at this as we introduce this whole concept of the vaccines. How do we start spreading a little bit of hope that that this is coming to beginning to come to an end, and that we'll get past this? So that's another component that we're still thinking through and going to try to dovetail it as part of this effort.
All right, well, thank you, Clayton. Kathy, the Hospital Association most certainly is playing a big role in getting this vaccine out. And I suspect the education for both healthcare workers and the public is going to fall on your shoulders. So perhaps you can share with us some of your thoughts on how we can be successful at this.
Well, gosh, Joe, I think I first want to join Clayton and be, you know, another Captain Obvious and repeat his initial words, which is, this is all about communication. It really is. You know, I take a look at what's happening with the vaccine and the vaccine hesitancy. You know, we did a statewide survey on behalf of the Department of Health to determine what the clinicians' uptake would be for the vaccine. We then did another survey to see all staff in the hospitals. And, you know, we were seeing that the clinicians were running at about a 60% interest. But I compare that to the willingness to take a flu vaccine, and, you know, we're all well above 90%. And so that delta tells us a little something about the hesitancy. But, you know, I take heart, or I look for hope in the fact that the first time we asked those questions, it was the end of August. And at that point, you know, we were also talking about Pfizer just going, you know, into the first weeks of its phase 3 trial. So I look at how rapidly, at warp speed, if you would, you know, this process has moved. And, you know, we've got the FDA hearing the Pfizer EUA on December 10th. We have Moderna's on December 17th. And we have a lot of data and a lot of science that will now back up, you know, the efficacy and the safety and the adverse events and contraindications for the vaccines that we think will emerge first here in our state. And I think having that information becomes key. And I can tell you right now, it is definitely one of our top priorities as NJHA. It's around, you know, prioritization. It's around the distribution of the vaccine, but it's also around how do we get a broad common, you know, acceptance of the vaccine and the benefits. How do we tie into that hope? And we're really fortunate to have a committee of healthcare CEOs, CMOs, COOs that are all working on developing a strategy for the effective deployment to our healthcare workforce. And one of the things that we're working through and with another piece of the task force is communications and engagement. So no doubt we're seeing some vaccine hesitancy out there. We just actually put out another survey on Monday where we're looking to see if there's been any change since the initial survey back in August. And that, I think, is going to be another key piece of the information. But we know that we have to overcome that hesitancy with information and with transparency. I look at healthcare, you know, not just as a science, although maybe the clinicians that are on this call would all say it's absolutely a science, but it's also an art form. And so, you know, I look at our workforce wanting to hear the solid facts, the facts about the vaccines and their efficacy. You know, they want to know what are the side effects. They want to have information they need to make fact-based, science-based decisions about whether or not they themselves will take it and whether or not they would actually recommend others to take the vaccine. But at the same time, and there's this art side, it's the human and the hope side. We also need to appeal to that strong commitment that our healthcare workforce has to protecting their patients, their loved ones, and the broader community against the virus. And one of the things I think we've seen through this pandemic is that healthcare providers are unfortunately always putting themselves last. They're not taking care of themselves. Then you've heard everybody comment on this. It's not just about the resiliency. It's actually self-care. And that's I think an important point. And they've got to put it through that lens that this is as strongly as it is for themselves, and for the broader community, that they can only continue to do what they do by taking care of themselves. So kind of looking at that, and as I look at it, our healthcare heroes, they're, I think, some of the most trusted voices out there. And so what we're looking to do is use those trusted voices of our clinical leaders and have them become champions for the facts and champions for the information on the art side, so that our healthcare workforce can first make a well-informed, science-based decision about the vaccine, and they can become the models after that first 1A distribution for the general community vaccine that will be available. I also think, though, there's another important piece here, and I know that this is a struggle even within our workforce, but we can't ignore the distrust that some in our more vulnerable communities have had, especially communities of color. And there's a long-standing, and I'm going to say it's like a justifiable skepticism of the medical science. This is something that we've heard, that that they've been victimized, and we see it by past research like the Tuskegee study. So I think it's going to be really important to be sensitive to that history, to engage closely with the community. And I think starting that engagement within our healthcare workforce and finding champions that can be, the voice as well within the healthcare setting, and then more broadly to the community setting.
All right, thank you, Kathy. Hopefully that the vaccine will, as predicted, help bring this thing to conclusion a little more quickly. So for our final question for this session, in the last 9 months, there's no question that healthcare workforce has remained highly engaged in providing care to both COVID and non-COVID patients. However, morale has most certainly suffered under the weight of patients presenting for care in the first surge. So for our panelists, how would you describe employee morale currently, and perhaps comment on any differences between what you're seeing in the clinical and non-clinical staff relative to morale? Laura, your thoughts, please.
Yeah, when I think about this, I think back to that first experience, and it had an effect on everyone, because we shut down so many programs and services. So there was an anxiety about individualized situations of work, and what was going to happen and when we were going to reopen, and all of that, which I think was a little more broad brush as far as the organization as a whole. This last few weeks, I've seen just so much more, what I would say, just frustration as well as anxiety, and people are tired of the grind and there's definitely a difference. I think, as I mentioned, with hundreds of people working from home, they're living through all of the challenges around their personal situation and their discomfort or satisfaction of working from home. But our frontline clinical people are really seeing up close and personally how tragic the situation has been for their patients and their families. And, as a nurse, not having a family member present when somebody is at the end of their life is so difficult. So I really am seeing a very different exhaustion and morale challenge than I did the first go round. And I'm very concerned about it. I think we're doing everything we can to support our staff and that are on the front lines, and teaming as much as possible, whether it's the proning group or having people have an opportunity to support one another. But it is just I'm much more concerned when I look at the difference between what happened in March, April, and May to what's happening now, and the fact that I'm very optimistic and have unbelievable expectations to kind of get this behind us with the vaccination efforts, but it's still weeks away and months away in some cases, and just the patients just keep coming. And what we're seeing also is people who have not followed through and had their traditional care issues ignored or put off, and people are, rolling in. Our ERs are packed today with people. We have COVID cases coming in, but we also have a lot of what I would call patients who have flare-ups of their chronic conditions because they haven't either been following up. So it's kind of like colliding. So we're busy on top of the fact that we're also trying to care in environments that is so difficult and, challenging for people who, served their whole lives to make a difference to their patients in the community, and not having that, some of the support like the family present is really, really a challenge. So it's a concern.
Yeah, for sure. And I think your observations about the grind, work home, homework, work home, people have no other outlet at the moment, unfortunately. So, Alan, your thoughts on this and observations, please. Alan, you muted.
Sorry about that. Trying to be proactive. Hit the mute. What I was saying is I think Lori was spot on. I think she nailed it as to what we're seeing also at Shore. It is that daily grind that is just grinding people down and making the coming into work even that more tenuous. An interesting development that I'm seeing, which is concerning from my viewpoint, is that the competitive nature and the fact that we have so many people out for either quarantining or out because of the COVID process, or even out because they don't want to be in the environment anymore. There is absolutely a shortage of qualified personnel, nursing, respiratory therapy, and the cost and the availability of having staff come to an organization, and for sure a smaller organization, is becoming more difficult. I have turnover because we have competition in the area that is ramping up the payment schedule for certain areas, ED staff or respiratory staff. And our staff is looking at it saying, well, if I'm not going to take advantage of the financial situation, if I'm going to work, I'm going to now try to work and maximize my income as much as possible. So the cost of these individuals, especially the agency, is starting to go through the roof. And I can't blame staff. If they're going to be putting these hours in, they're going to try to maximize as much as they can make during those situations. NJHA put out a little thing last night from the registry that was very telling in regards to where things have gone. And most of this is over a relatively short period of time, the acceleration of these rates. So the trade-off is people are, as Lori described, feeling worn down, feeling that they are at a wit's end in regards to home, work, but they're also looking at, well, how am I going to make this work for me, and how am I going to take advantage of what may be out there? And over the last couple of weeks, we're seeing more of that come about. So, we are trying to work and create the best supportive environment for people to come to work every day and make it as conducive as possible. But there's only, I think, so much that we as an organization can do. And I think all of us on this panel are starting to feel the same type of wear that our employees are sharing with us, and trying to find creative ways to help them feel encouraged that when they are coming in, they know that they're making a difference. But it's getting harder.
Yeah, I think we all look forward to this being in our rearview mirror as quick as possible, and not looking forward to another pandemic in our career. All right, at this time, I'd like to ask each panelist for closing remarks relative to the workforce, either COVID related or even more forward looking. Let's start off with Stephanie, please.
Sure. I think one of the biggest things I learned is that, and I continue to learn through this process, is to be flexible, adaptable, while being forgiving. Clayton mentioned the idea that they're either going to be, it's going to be received 50% well or 50% negatively. I think that through all of this, every decision that we've made, it's sort of, putting something out there and trying it. And sometimes it doesn't work. And, with myself and my leadership team, we've had to just be very forgiving that, we're trying our best here. And, we're trying to learn from other organizations and implement best practices as best as we can. But, there have been times that we've made a decision where we've had to sort of pivot and shift gears pretty quickly and go a different route. And so, that's something that with the workforce and implementing, programs, changes, response planning related to COVID and just day-to-day practices is, we've just really had to be flexible, adaptable, and, like I said, just forgiving of those choices. Something in COVID that I've learned is that you can never have enough PPE, no matter what it feels like. We get ahead and then, we're down. We might be good in, gloves, gowns, and face shields, but we're down in disinfectant wipes. So it's, there's never enough. And then something that, I think was a lesson learned from us is that when we first opened, our testing was taking a very long time to come back, our PCR test. And we invested in a rapid testing device. And this has made a massive impact to our day-to-day operations and to our workforce so that we can prevent critical staffing needs, that we can test staff very quickly and have a 15-minute turnaround and have somebody report to the floor. And then people feel confident then, when their coworkers are coming on and they've been tested, they may have had exposure. And so that's been something that's been very helpful to us. And then of course, with our patient care, having that quick turnaround, it's just really been able to accelerate our actions and what we do.
All right, well, thank you. Lori, your thoughts, please?
I would just reemphasize how important it is to be transparent to all that are involved in this journey with us, whether that's helping and being honest with the business leaders in the community, answering their questions, being, available and really present. I've increased my rounds in the hospitals, in our clinical sites. People need to see leaders, and I need, as our leaders, also need to hear what people are going through, and whether it's, having just the ability to hear their story, but also then to take some of their feedback and hopefully improve a situation if there's something that we can do to support that. And that the communication that kind of weaves that all together is critical. We've gone back to pretty much our former COVID models of communication. And one thing that we do that people really get a lot out of, with our head of infectious disease, do an every other week now, and probably will get to every week again, where we host an update, and that's then available to everybody live or in a video. But people want to know what we think as leaders and what we're working on. And sometimes when you don't have an answer, you need to say that, but you also need to be just as incredibly honest as you can, so that people can believe that we're getting through this together.
Thank you, Lori. Clayton, your final or closing thoughts, please.
Sure, it builds off of what Lori was just talking about. The old saying is everything rises or falls in leadership. I think in the middle of a crisis and a pandemic that we're going through, people are looking for authentic leadership, and leadership that's consistent, leadership that creates a safe place to work, but also a safe place emotionally and mentally, and being able to share, and also leadership that cares. And so I think that it can't underscore enough the importance of spending time with your leaders and helping them understand what it means to lead authentically through a crisis. History will judge us as leaders. We know that. And so what do we want to be judged on, and how do we want that to look? That's something that I would put out there. And finally, I'll just leave it as I leave all of our meetings with our leaders, be kind to everybody, because everybody's having a tough time.
All right, thank you. Kathy, your final or closing thoughts, please.
So I'm positioned a little bit differently because we don't have clinical, and at NJHA, I want to maybe take that perspective. I think for us, as we look to the future, I think that we have to figure out how to build a new type of culture. We are, we're an organization that has been built on, interpersonal relationships and the types of informal communications that take place, whether it's over a coffee or, stopping into someone's office. And this move to a virtual environment has really disrupted that sort of interplay. And so I do think, as we move forward, that we have to think about how do you inject that level of informality that develops relationships so that you can easily pick up a phone, place calls, and how to take those relationships and leverage it out to a broader community at the same time. That's going to be, I think, one of the big struggles that we face, and then frankly, a lot of businesses are going to face on a move forward basis. It's really easy, I think, to do the job at hand and to do the tasks and to come together as teams on, virtual calls. But it's really hard to make it over that next hurdle where you build that intense trust that you need, especially when we have times like now. And you see it during this pandemic, our healthcare leaders statewide were able to coordinate and come together, but without having had the personal interactions that developed over a shared meal, for example, I don't know it would have happened with the same degree of efficacy and the same degree of trust that someone was not only having your back, but providing a helping hand to pull you forward.
All right, thank you, Kathy. Alan, your closing thoughts, please.
Yeah, one of the things I think is important to recognize is in the beginning of this pandemic, I think we all talked about the fact that we had every community member out there giving us food, making donations, coming in, helping us out, signs everywhere, thank you for the heroes, thank you for the great work. And I am so proud of my team because I do believe that they are all heroes and go above and beyond providing care in this area. But that momentum of that recognition from the community has shifted over the last couple months. The community is now a little bit more apprehensive. There's the fear that's now developing in regards to coming into the hospital and that they're not being safe and not having all the appropriate care, which is a falsehood, but that's some of the things that is happening out there. I'm really struggling on how do we re-engage with the community to make sure that they understand that healthcare is safe. We are taking all the right precautions. We are there for them. We want them to use them. We don't want to get into a situation, as was described before, where they're not taking care of themselves. And when they do come into the hospital, the acuity of their care is much more critical at that point in time. So the engagement between the hospitals themselves and the community, I think we need to re-engage so that they understand that nothing has changed from the beginning of the pandemic to where we are now, that we are still the place, we are still the appropriate care settings, and all of us are doing all the right things for making sure that our community is being taken care of.
All right, thank you, Alan. All right, in closing, I want to thank Withum for putting this together. I'd like to thank the panelists. I think they've demonstrated this was the best panel. Just saying again, I'm biased in that opinion, but I think I'm right. And I want to thank the attendees for hanging in. I know it's been a long morning, but I think it was well worth their time. So I guess I'm handing it back to either Mike Cerluco or Scott Mariani or Rachel, I'm not sure.
Thank you all so much. We're just going to do our last two polling questions, and then we will conclude the program. Have you hired telehealth providers in new states during the past year? $20 more seconds. All right, I'm going to close it out. Here are the results. It looks like 50% of you voted no. And then onto our final polling question. Have you renewed your organization's respective state sales tax exemption certificates in the past 5 years? $15 seconds. All right, I'm going to close it out, and here are these results. Looks like 39% voted yes. Yeah, looks like you still can't hear Scott.
Yeah, Scott, I'll pick up. Thank you very much. For some reason, your volume's not coming through. I'm happy to see that virtually all the attendees stayed on for the entire presentation. I agree with you, Joe. I think it's because we saved the best panel for last. So thank you very much. What a great discussion on employee and workforce issues during the pandemic and predictions as to what's going to happen in the future. Just a great job throughout the entire symposium today by all of the moderators and panelists. Thank you very, very, very much. I'm confident that all of the participants that stayed on today have learned a lot. They're excited. They're going to be able to take some of the ideas and best practices back to their facilities later today or later in the week. So just to kind of conclude, I'm going to reintroduce, I don't need to, but bring Rachel back for some final housekeeping comments and a wrap up. Thank you all very much.
Thanks, Michael. And thank you everyone for joining. Please remember to complete the survey after this webinar to qualify for credit. Certificates will be distributed in a few weeks, and you will receive your CPE certificate from Withum and CLE and ACHE certificates from NJHA. Please also feel free to register for our upcoming webinars, which are hyperlinked in the presentation handout, and save the date for our symposium next year on Wednesday, December 8th, 2021.
Thank you all very, very much. Have a great holiday season.
Thanks, everyone.